biophysical profile. We have NST, we have contraction stress tests, amniocentesis, and chronic velocity sampling. So these tests, we are going to look into them, all right? So we are looking into the first one is
Please, your voice is faint. Oh.
all right. All right, so we are going to look into biophysical profile. Okay, that's our first thing that we are going to look into. And biophysical profile, as the name goes, is like we are looking into the thing that will have the child live. Okay, we are looking at the physical thing, and this thing is a non-invasive. All right, so we are assessing the well-being of the child or the fetus. Okay, and mostly it depends on the neurological function. The well-being of the child is all about the fetal or neurological function. All right, and we are also looking into whether the fetus is developing hypoxia or not. Okay, so well-being, that is neurological function as well as hypoxia, using two things. Okay, that is ultrasound and what? EFM. That's electronic fetal monitoring. All right, device. And we just want to determine 5 scores, okay, or 5 criteria. And that is breathing, fetal movement, amniotic fluid, volume, and what? Muscle tone, as well as what? Fetal heart rate acceleration. Okay, so we are dealing with 5 things. 5 things. So biophysical profile has to do with 5 things. All right. So we normally call what BMAT. That's B for breathing, M for movement, fetal movement. Okay. A for amniotic fluid, volume index. All right. And M for muscle tone. Okay. And together with fetal heart rate acceleration. That's non-stress test. Are you please okay? So that is what we do.
No, please, I didn't get the acronym.
Yes, can
Or
you
the
please go over the
mnemonic.
acronym?
Acronym, I said BMAT. Okay. B for breathing. M for what? Movement. The fetal movement. Okay. A for what? Amniotic fluid. All right. And M for tone, muscle tone. Sorry, T. So we have BMAT. B breathing. M movement. A amniotic fluid. And T is for what? Tone plus NST. That's non-stress test. And that one has to do with what? Heart rate acceleration. Are you good? Are you please okay?
Yes, please.
All right. So that is what biophysical profile assess. Biophysical profile, that is what it assesses. So it assesses BMAT. That's breathing, movement, amniotic fluid, and tone plus what? NST. And then NST, as I told you, it has to do with your fetal heart rate acceleration. You want to see if the fetal heart rate is accelerating. All right. And why do we do biophysical profile, BBP? Why do we do that? All right. We do it for those, as at the beginning, as I said, those with high risk problems. All right. So pregnancies that are at increased risk of what? Having placental insufficiency or stillbirth. So anything that will have a cause okay, on the fetus, okay, the fetal compromise. Anything that will compromise the fetal or fetal neurological function, okay, that is indicated for BPP. All right. So if the child is not receiving enough oxygen, all right, it's going to affect the fetal movement, the breathing, as well as the tone, and together with the heart rate. All right. So if you have post-term pregnancies, those people are also at risk, okay, of what? Fetal compromise. All right. And if the patient or the mother reports that is having decreased fetal movement, okay, there's a decreased fetal movement. I'm not been feeling the child move. Okay. That case, we can do BPP. You understand? And if patient is having preeclampsia, okay, diabetes mellitus, all these things can be indicated for BPP, okay? And IUGR, that is intrauterine growth retardation. The child is not growing. The fetus is not growing in utero, okay? Oligohydramnios, okay? It's all these things will have effects on the fetus. So anything that will have effects on the fetus can be an indication for BPP. Please, okay. And mostly these things are performed in the third trimester. Okay, in the third trimester after 32 weeks. All right. And because they are 5, that is BMAT, breathing, movement, amniotic fluid tone, and heart rate. All right. So the maximum score that you can get is what? 10. That is 2 for each. All right. Ideally, it comprises of breathing, movement, amniotic fluid, and then fetal heart rate. Okay, but because we've added NST, okay, that's the fetal heart rate. That's why we say that 10 point is okay, but 8 is normal. So 8 will be for the 4. Okay, so when it gets a maximum value of 8 to 10, that is normal. All right. But when you have abnormal findings, okay, you're getting less than 6, 4, you're getting 4. Okay, it would suggest that the fetus is developing acidosis or developing hypoxia. Are you please okay? Because all the indication that we've talked about, gestational preeclampsia, diabetes, hypertension, post-term, they all can have effects on the fetus, okay, to develop hypoxia if the fetus is not getting enough oxygen, because oxygen, the fetus depends on oxygen for its growth. Are you please okay? So if it's not getting enough oxygen, it's going to affect the fetus. All right. So whenever you have abnormal finding below 6, from 6 downwards, it tells you that the fetus is developing hypoxia or acidosis. I please okay. So the main purpose that you should know for your NCLEX is that we use this to determine what? The neurological function of the fetus, the well-being, as well as if the child is at risk of developing what? Hypoxia or acidosis. Okay. And if you want to examine the fluid, what are you going to use? Ultrasound. I think okay. So if you want to know the heart rate and those stuff, that one has to do with what? EFM, the fetal monitoring. You understand, please? Are you okay?
Yes, sir. Yes, please.
So that's why we use these 2 devices. Okay, ultrasound. Ultrasound would determine the fluid index. Okay, the fluid index by determining each pocket. All right. So, and you know that fluid that the child leaves or the fetus leaves is also part of him. Okay, and that one will help in the neurological function. All right. So we use ultrasound to determine the fluid, and then the fetal monitoring will just know the heart rate if there's acceleration. All right. So that's what we do. Okay. And we are moving on to NST.
Well,
NST.
Frank,
Yes, please.
please, before you move on, I want to understand something here.
Okay.
So it means that the ultrasound done after 32 weeks is is a biophysical profile ultrasound that is supposed to check these things. So it's typically done by a sonographist, right? Apart from
Yes.
the NST and then the fetal monitoring that NS can do, the rest is done by a sonographer.
Sure.
Okay.
This one is done by sonographer. You, the nurse, you have to know that we have to monitor the feed peoples. Okay. You have to look at the
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 parameters to know.
yes, the parameters, the
Okay.
fetal monitoring. You have to know how if there's acceleration. Okay, that's the stress test. So this
Mm.
one, we are not going to give any medication to the mother. We are not going to stimulate any contraction. That is why we call it what? Non-stress. They're not going to stress the uterus. All right. We
Mm.
just want to know if while the child is moving, because when the child goes up from 32 weeks, okay, the neurological function, okay, movement, all affect the child's heart rate. That's why it's ideal to measure it from around 32.
Okay.
Because
Please,
neurological
so
function affect them, all these things. Yes, please.
okay, so I saw you said the maximum score is 10. I want
Yes.
to know how the scoring is done, or it is not the work of a nurse to do that.
No, this one is not a big. They just give 2 for each. That's how they do. If the what's the name? If you check and then the child is maybe not there's no breathing, there's no breathing activity. Okay, you've seen your child, there's no breathing activity. Then we are going to score it.
0.
Yes. Okay. So it's like using ABGA score. How we know that?
Okay.
So if there's maybe breathing or if there's no the breathing is okay within normal range, then we give 2. So it's like not ABGA score. All right. So just know that the normal is 8 to 10. 8 in a sense that we are eliminating the NST, because ideally it should be the breathing, the movement, amniotic fluid, and the muscle tone. So when we just add, that's the newest this thing approach. We are adding the NST, and that makes it 10. Okay, but so you get 8 is normal. I please okay. Do you please understand?
Yes, please.
Can you please move on?
Bro, please, I wanted to clarify something, please. So,
Pardon?
please, for the indications, I can see something like IUJR. I didn't hear maybe the full listen for it, meaning for it.
Okay, who can help?
Intrauterine growth restriction.
Okay. Thank you.
I please, okay.
Yes, please.
Please,
Thank
is
you.
it retardation or restriction?
He said,
Is it retardation or restriction?
which one?
You, the person that answered, she said intrauterine growth
Restriction, yeah,
restriction. But
restriction,
I
yeah. Try and do restriction.
okay,
Yes, please. Intrauterine
okay.
growth restriction.
Restriction.
Are you okay? So
Yes, please.
when the child is not growing, okay, the child is not growing, you have to know what is happening. You have to know the bio. It's like writing someone's bio. All right. We know when the child, the bio has to do with the breathing, how the child moves, the amniotic fluid that is living, and then the tone, as well as the heart rate. All right. So if the child is not growing, you have to know, is it because the child is having limited fluids, or how is it affecting the heart rate and those stuff? Okay. And with that one also, there's going to be effects on the child's neurological function. That's why we have to look into all these things. I please, okay.
Yeah, Boss Frank, please, can I understand the fetal breathing? Because breathing starts when the baby is born, but this one is still in the uterus. How is it going to be assessed?
The breathing,
Yes, please.
yes, with the help of ultrasound, you will see it.
Oh,
Because
okay.
we are using ultrasound, and ultrasound would just view the fetus, and then when the child breathe, the fetus breathe, you see the rise of and fall of the chest. I please, okay.
Oh, okay. I never knew they breathe in the uterus. Okay, thank you.
They do bad.
Oh, okay. Thank you.
All right. NST. This one is also evaluating the well-being. The oxygenation, autonomic nervous system function. Okay. So because NST, just know that NST is equivalent to what? When you talk of NST, what are you talking about?
Fetal
Fetal heart rate, right? Heart rate acceleration. All right, thank you so much. So we are looking at and then heart rate, it has to do with the autonomic nervous system. All right. And if there's decreased oxygenation, it's going to affect the child, what? The fetus, what? The heart rate of the fetus. Okay. So we are assessing the heart rate in response to movement. Look at the word. In response to fetal movement. That's why we call it non-stress. We are not going to cause any contraction. We are looking at how the fetal movement affects the heart rate. I please, okay. How the fetal movement affects the heart rate. So whenever the child moves, we should see an increase in the heart rate. Are you okay? We should see an increase in the child heart rate whenever the child moves or the fetus moves. Okay. So when the child is healthy or well oxygenated, there's going to be an acceleration. That's an increase in the heart rate. Okay. And temporal increase. All right. With the movement. And usually 20 minutes and may extend to 40 minutes, as we saw the last time. 20-minute period, and they are done. Okay. They want to see within 20 minutes how many times the child movement affects the heart rate. Okay. And this one, we are looking at acceleration. We are not looking at deceleration here. Because non-stress test, we are looking at the acceleration. If the child moves, how does it affect? How is it going to cause an increase? All right. That's what we are looking at. And as with the BPP, when there is an indication that's affecting the oxygen. Okay. We have hypertension, GM, decreased fetal movement. They are all indicated for NST. Okay. And what do we use? We use ultrasound transducer. So ultrasound. Okay. We have a transducer that they sometimes they have a belt that they place on the pregnant woman's or abdomen. All right. And that will monitor the heart rate. Okay. Know the acceleration and deceleration. That's what the monitor does. Okay. The ultrasound transducer. And this one, they are placing it. Is someone talking?
Bill, what have you done? Don't there anything, but I wanted to
Sister Efua.
Where do you go?
Sister Efua, please try to mute. All right. So with this, they are just assessing the heart rate if there's acceleration or deceleration. But know that NST mostly deal with acceleration. Okay. And we are placing over the area where the fetal heart tones are best held. Because external ultrasound transducer, we are assessing the heart rate. So where the fetal heart rate tones are best held, that's where we are going to place the ultrasound. And we have Togo, okay, Togo dynamometer, all right? And this one, we are measuring the mother's contraction. Okay, measures contraction, fetal movement patterns, all right? And this one is placed over uterine fundus. But note that, as I said, this one, we are not dealing with what? Contraction. What are we dealing with? What are we dealing with?
Acceleration.
Fetal heart rate.
Acceleration. How does
Yes.
acceleration come about?
By the-
Fetal movement.
Fetal movement. Very good. Fetal movement. So the Togo dynamometer will measure the contraction, okay? Fetal movement placed over the uterine fundus. So this one will know when the child moves. All right, we're going to take a measure, okay? And that is what we do. So the last time we're thinking of button, okay? As I said, the Togo dynamometer is enough to measure the movement. Please try as much as possible to mute, okay? Please. All right. So as I said, with this, the Togo dynamometer measures the contraction, the fetal movement. All right, and it's okay. But in cases where we want to know exactly where the fetal moves, okay, that's where they sometimes give the mother a button to press. Okay, and once the fetus moves, the mother will just press it. Okay, but know that the Togo dynamometer will assess the fetal, the maternal contraction, the fetal movement, and but this one is the Togo dynamometer is placed over where the fundus. Okay, because that's where we are going to measure contraction. and that's where it's going to measure movement. Okay, so we place the total dynamometer over the uterine fundus. All right, and we also have to do we need electronic fetal monitor. Okay, that will display the acceleration, the fetal heart rate. Okay, that's what you should know. And the mother is placed in semi-fowless or left lateral. We just want to avoid supine hypotension. So that the mother shouldn't be placed in supine position. Always the mother should be in semi-fowless or left lateral. All right. And what will be the end result? We have reactive NST and non-reactive NST. That's what we should know. Okay. And what do we say? When do we say is reactive? Because as I told you, we are looking at heart rate movement going up, acceleration. So if we measure within 20 minutes, okay, within the 20 minutes, we see 2. So 2 for 2. 20 minutes for 2 movements. That's 2 acceleration. Okay. And then it should go as high as what? 15 beats per minute above the baseline. So if you have a baseline of, let's say, 120, okay, the fetal heart rate is 120. And once the child moves, it goes to what? 135. Okay, we get maybe first movement affecting heart rate going up to maybe 135. And then with the next 20, maybe 5 minutes time, 10 minutes time, we also see acceleration, child movement, okay, and we get acceleration. So we should get at least 2. Okay, the least that you should get, within 20 minutes is what? 2 acceleration. All right, please, okay? But the heart rate should go above what? 15. From 15 and above the baseline, sustaining for 15 seconds. That's what we call acceleration. Okay, and that is a reactive test. So 2 acceleration within 20 minutes, 2 for 2. 15 beats high above the baseline for 15 seconds, 15, 15. So we have 15, 15 to 20 seconds, 20 minutes. 15, 15 to 20. I believe it's okay. 15 beats above the baseline. So it should go up. Let's say the heart rate is 130, it should go up to maybe 145, 145. And then it should be there for at least 15 seconds. Okay, 15 seconds. And then it comes back to normal, 130 as the baseline. And it hovers around that. Okay, so 2 acceleration within 20 minutes, 15 beats per minute above the baseline for 15 seconds. That's what we call is reactive. Okay, and mostly it's for those above 32 weeks. If the child is the fetus is 32 or greater, you should get this. But sometimes if the fetus is just less than 32, if we get an increase of 10 beats sustaining for 10 seconds, that's okay. Okay, so above 32, it should be 220, 15, 15. Less than 32 weeks, if you get, it still should be 220 but 10, 10. For less than 32 weeks. Are you please okay? So that is reactive. That's what we say is reactive. And when we say it's non-reactive, it means that we didn't get at least 2 acceleration, insufficient acceleration. Okay, and that may be an indication that the child is sleeping, or we're giving the mother medication to sleep. All right, or the fetus is developing hypoxia or acidemia. All right, but know that the NST sometimes, okay, will produce high false positive. And that doesn't always mean that, okay, the child is having what? Having fetal compromise. You are having fetal compromise. So when we get non-ST, that always indicate that the child is compromised. Okay, that's why we have to do a follow-up test by doing biophysical profile and CST. So know that BP and CST always follow what? NST. Are you please okay? So when we do diagnosis or we do assessment and we see that we are getting an NST and non-reactive, it doesn't always indicate that we are having fetal compromise. You have to go further. The heart rate alone, if it's not accelerating, doesn't always indicate that we are having compromised baby. Okay, you have to do other tests. You have to know the movement. Is the child moving? Is the amniotic fluid okay? All right. Is the tone okay? Is it able to move around? Is it breathing well? By doing what? Biophysical profile. Okay. So that's what we should know. And we can also go further and do contraction stress tests. Any question? All right. Our next thing is contraction stress test. Okay. And this one evaluates uterine contraction. So know that NST, we are looking at child movement affecting heart rate. That's having acceleration. All right. And biophysical profile has to do with what? The BMAT plus NST. And with contraction stress test, we are stressing the uterus. We want to stress. That's why we say contraction stress. So contraction will cause stress on the fetus. All right. So we want to know if the fetus can maintain enough oxygenation during contraction. So during delivery, because whenever there's delivery, normally, ideally, when there's contraction, it causes decrease in oxygenation. True or false? True or false? Hello?
Yes.
Please
Hi.
come again. We couldn't hear that point well.
I'm saying that contraction always causes decrease in fetal oxygenation. True or false?
It's true.
It's true,
Hey, yes, true.
right? Whenever there's contraction, because contraction will cause decrease placental perfusion. And once there's contraction, the vessels, okay, that the veins and the arteries, they all constrict, reducing blood supply to the fetus. So whenever there's contraction, it decreases oxygenation to the fetus. So during contraction, we want to know, will the child be able to sustain? Because when the fetus is normal, okay, normal fetus, when there's contraction and there's decreased oxygenation, the fetus is able to compensate. But when the child we're having compromise, all right, the fetus can't compensate. So when we want to know, during contraction, during labor, will the baby be able to sustain? Okay, decrease oxygenation. That is how to do with what? Contraction stress test. Okay, and know that with this one we are looking at contraction. So we should have at least 3 contractions within 10 minutes. 3 contractions lasting, that is duration, for what? 40 to 1 minute, 40 seconds. Okay, so one contraction lasting for at least 1 minute. How is the child going to sustain? It's like vitals, checking your vitals. We always take it for 1 minute. So if there's 1 minute contraction, will the baby be able to sustain? Okay, will the baby be able to have? Will the baby be able to compensate? Okay, because of this what reduction of oxygen. All right, please. Okay, but we aim at 3 contractions, not more than 5. When we have more than 5 contractions, what do we call it? Tachystool.
Tachystool.
Okay. We call it what?
Tachystool.
All right. So that is what we should know. And that one, once the contraction is so frequent, as we've already established, it's going to decrease oxygenation. And the fetus is going to be in compromise. So we don't want to cause tachystool. We just want to have at least minimum contraction that will be able for the child to be able to sustain. So 3 contractions is okay. We've passed the test. So once we have 3 contractions and each contraction lasting for about at least 1 minute, how is the baby going to sustain? Okay. So we just want to develop and determine risk of fetal compromise during labor or uteroplacental blood flow adequacy. Okay. And indicated when we have NST, non-reactive. Once we've done NST and it's non-reactive, we have to do further tests to rule out if the child is at least compromised. Okay. So when we do NST and it's non-reactive, we have to do further tests. When we have DM, HPT, post-term, like those that we already talked about. Okay, but know that this thing, we are inducing contraction. Okay, and we already know that placenta previa, we don't do what? Want to cause contraction. Because placenta previa, I hope you know placenta previa. Do you know placenta previa?
Yes.
Yes.
Yes. What is it? Placenta previa. Where is the placenta lying?
It's supposed to attach itself to the fundus area, but and placenta previa comes below. It can be at the should I say orifice or of the cervix, such that it blocks the child from being able to come out during labor.
All right. So when the placenta is positioned just close to the cervix. All right. And you know, once there's contraction is going to cause effacement and dilatation, right? And once the cervix is dilated, if the placenta is just close to the cervix, it will be detached. Okay. So with placenta previa, and if it detaches, it will cause bleeding. So in placenta previa, you don't want to cause contraction. So once you know that the mother is having placenta previa, don't do contraction. Okay. And preterm labor risk. Okay, preterm. The mother is at risk of what? Preterm labor. And you're going to induce contraction? No. Okay. What are you going to use with contraction stress test? We use the monitor because we just want to know the heart rate. How is it? And then oxygenation. So we have to use external fetal monitor to measure the fetal heart rate. And this one, know that we are focusing more on the deceleration. NST, we are focusing more on acceleration. And contraction stress test, because this one, we want to know if the child will be at risk. So deceleration will mean that the child will be at risk. That's what we want to determine. So once there's deceleration, that means this result is what? Positive. It has produced its exact effects. Are you please okay? Are you okay, please?
Please come again for me.
What I'm
Yes,
saying is
sir.
that once there's contraction, it will reduce placental blood flow. True or false?
True.
What is number one cause for deceleration? Late deceleration.
Placental insufficiency.
Placental
Yes.
insufficiency.
So once there's placental insufficiency, what is it going to produce? Deceleration.
Yeah.
Okay. So contraction stress test. Once there's contraction and there's decreased oxygenation, and it causes the heart rate to decrease, it is called positive, because it has produced the desired effect. Because contraction will decrease oxygenation, and oxygenation will cause a decrease in the heart rate. So it's positive. And positive, do you think it is bad or good? Do you think this one will be bad or good?
Bad.
Bad. So note this, that with contraction stress test, positive means what? Bad. There's a problem. Positive means problem. Are you please okay? Please mute up. Are you please okay?
Yes, boss. Thank you.
So that is it. Okay, so we use external fetal monitor to monitor deceleration. Okay, and let me say this, with the non-NST, with the NST, sorry, we are looking at what? Acceleration, isn't it? We are looking at acceleration. All right, and once we have moderate variability, that's okay. All right. Okay, so we also use thermometer, and this one, as we already established, measures the contraction, okay, frequency and duration, and this one is played over the fundus. All right, and this one, because we are inducing contraction, we need to get what? Oxytocin infusion pump, oxy infusion pump, because that will oxytocin will cause contraction. All right, and this one mostly we mostly start with spontaneous contraction. And how is spontaneous contraction done? We use what? Nipple stimulation. Okay, we stimulate the nipple. That's why the ladies, when you stimulate their nipples, there's a problem. Okay, nipple stimulation will cause contraction, because nipple stimulation will release oxytocin. Okay, so that's what you have to know. But if we are using oxytocin and there is tachycystole, what are you going to do?
You stop it.
You stop the what? Oxytocin.
Oxytocin.
Because tachycystole will cause what? Further decrease in what? Oxygenation. And we know once oxygenation, there's decreased oxygenation, is going to produce what? Deceleration. So once there's tachycystole, when do we say there's tachycystole? If there's more than what? 5 contractions in 10 minutes. Because this one we are looking at 10 minutes. 10 minutes. Know that NST has to do it. 2 acceleration within 20 minutes. That's 15 beats above baseline for 15 seconds. But with this one, we are dealing with 10 minutes for 1 minute. 10 minutes with three contraction, and each lasting for 1 minute. That is 40 to 60 seconds. Okay, that's what you should know. And the interpretation are two. We have negative and positive. I've already talked about positive. Positive, it has produced its desired effect because contraction, we call it positive because contraction will cause decreased oxygenation and it causes deceleration as well. All right. So once we induce contraction and it produces all these things, we say it's positive. And this one is bad because deceleration is not good. All right. So deceleration is not good. So if you have positive, we say it is non-reassuring. But negative is good. Negative in a sense that we are seeing no late deceleration. Okay, and we are not having any variable of deceleration. That is no cord compression. All right. So with adequate contraction, if we are having no deceleration with no significant variability, okay, we say it's negative, and that's good. But positive will always have what? Late deceleration, and that mostly occurs about 50 or more percent of contraction. Okay, we are having every time there's contraction, there's deceleration. So more than half of contraction, it's resulting not late deceleration. All right, and we know this one has to do with what? Uteroplacental insufficiency. Okay, and sometimes we are having unsatisfactory. That's when we have fewer than 3 contractions in 10 minutes. Okay, that's unsatisfactory because we said we should have at least 3 contractions. 3 contractions in 10 minutes. Each lasting for 10 seconds. 1 minute. That's 40 to 60 seconds. Are you please okay? Any question? Any question? All right. If there's no question, we are moving on to amniocentesis. Amniocentesis. This one is an invasive procedure. Okay, and this one is diagnostic procedure as well. Know that amniocentesis is a diagnostic procedure. And look at the word amnio. We are looking at amniotic fluid. Amniotic fluid. So when we obtain it by needle, okay, we have a needle. All right. So once we insert a needle, about 20 to 22 gauge spinal needle, all right, through where the maternal abdomen, okay, into the amniotic sac and the continuous ultrasound guidance. This one uses ultrasound because we are passing a needle through the abdomen. So possibility of injuring the child is high. So that's why we have to do it under ultrasound guidance. Are you please okay? So know that we historically they used to assess lung maturity because if you are using the amniotic fluid, okay, because the same amniotic fluid that the child's what's the name? It contains this thing called what? Lecithin and what? Myelin. Okay, lecithin and sphingomyelin. So they do a ratio, and if we are having enough of it, we say the child lung is what? Fully matured. Okay, so they use it to assess lung maturity. They use what? The amniotic fluid. because the amniotic fluid, it passes through the fetal line. Okay, and it produces this thing, lecithin and what? Phenogomyelin. All right. So once they assess and you haven't at least sometimes the ratio of 2:1, it's okay, and then they will know that the lung is fully matured. All right, and it's the same fluid that they use to assess genetic. Is someone talking? All right. So the same fluid that they use to assess if there's a genetic disorder, because the fluid will contain some of the cells of the fetus. All right, because the fetus, and it contains the fetal particles or tissues. All right, so they use this fluid, amniotic fluid, to assess if there's what genetic disorder, if there's chromosomal disorder. So if there's Down syndrome, all right, if there's these chromosomal disorders, if you have Turner syndrome or trisomy 13, trisomy 18, all right, or if there's genetic disorders like what? Cystic fibrosis, or is the child having sickle cell disease? Okay, this amniotic fluid, which contains the tissues of the child or the fetus, will help assess all these disorders, genetic and what? Chromosomal disorders, by using what? Amniotic fluid. All right, and that is the help of what? Amniocentesis. And they can also do what? Neural tube defects. All right, neural tube defects. If there's spinal bifida or anencephaly. What is anencephaly? What is anencephaly?
Is it no brain in the scalp or something? Or
We said?
I'm not sure, but I think it's no brain or small brain in the scalp of the child.
Okay. So when we say anencephaly, a means without. Okay. So we mean that the child is just having small parts, okay, of the brain. Okay. So that's what you should know. So if these are all neural tube defects, okay, so the brain and the spinal cord, that is neural tube defect. So if the child is having neural tube defects, they use the amniotic fluid. Okay, so these two things, please take note: genetic chromosomal disorder as well as neural tube defect. Okay, but before, sometimes they also use to assess if we are having RH amnio allo immunization. Okay, allo immunization. That's what you should also take note of. All right. So, with this thing, mostly is performed within the half part of the gestation. Gestation is what? How many weeks?
Yes.
How many weeks of gestation?
It's
40.
42.
Okay, so ideally 40. All right. So if we are having at the middle, so 15 to 20, most times they do perform what? Amniocentesis. Okay. But know the priority assessment as a nurse. Number one is if you are passing a needle, okay, to the amniotic fluid, that's where the child, the fetus lies. All right. And know that you can injure the fetus, and the fetus cannot bleed. When the fetus bleeds, the blood will pass through the maternal blood. All right. And if we are having blood incompatibility, what is going to happen? What is going to happen? Bleeding. Okay, because the mother's blood is incompatible with that of all the fetus. And if it happens like that, we are going to have destruction, hemolysis. Okay, so please know that once we are passing a needle, you don't want the blood to mix. All right, so your priority is what? Maternal tide. Okay, know the maternal tide. If you are going to do this procedure, know the maternal tide. What's the RH status of the mother? Is the mother negative? If the mother is negative, no, anticipate that we are going to give what? We are going to give what? Yes. Okay, we are going to give that. All right. So know that. And wait. Is someone talking, please?
Yeah, hello, sir. Hello, sir. Hello.
Yes.
Well, sir, sorry, I wasn't getting you clearly about the part of blood mixing. You were explaining, I wasn't getting.
What I'm saying is that if the mother is negative, okay, mothers are always negative. If the mother is negative, know that, and we are going to give what? Rogam. Okay, ROD, immune globulin.
Okay.
We are going to give immune globulin. And that's the name.
Okay, sir.
Are you please okay?
Yes, okay.
And that is going to prevent what? The hemolysis.
Okay.
Okay, that is going to prevent agglutination. That's the mother's blood not forming antibodies against the child. All right.
Oh,
So
okay,
that's why
sir.
we give. So know that always when the mother is negative, because we are passing a needle, there's possibility of injury, bleeding, and we don't want the blood to mix. So we always anticipate giving Rogam at the end of the day. All right?
Okay, sir. Understood.
Yes. And this one, do you think informed consent is necessary? Do you think it's necessary?
Yes.
Yes, please, because
Because
an invasive
it carries
procedure.
risk. All right? It carries risk. So please obtain informed consent form. All right? And we know that we have to also know that the baseline of the fetal heart rate. What's the fetal heart rate? Because if after the procedure, number one thing that it should be your priority is also assessing fetal heart rate. Are you please okay? Assessing fetal heart rate. These two things, don't forget the RH type or status of the mother, as well as the fetal heart rate. Because if there's a needle prick to the fetus is going to bleed. And once it happens, you know what is going to happen. Okay? Decreased oxidation. And decreased oxidation is going to cause what? Deceleration. Isn't it? So we have to what? Assess the fetal heart rate both before and after the procedure and do comparison. Has there been in any deceleration or decrease in fetal heart rates? Okay. So that's what we should focus on. All right. We should focus on assessing fetal heart rate by comparing before and after, and knowing the RH status of the mother. Very, very important. Before the procedure, the most important thing is to know your fetal heart rate as well as the mother's blood type. Okay, the RH status of the mother. That's very, very important. Okay, and as a nurse, you should witness the signature of the consent form. All right, witness that. Okay.
Hello, boss.
Yes, please.
What if the mother is a resource positive? What if the mother is a resource positive? Will she still need the immuno?
No.
Okay.
Only when the mother is what? Negative. Please take note. Negative, not a positive mother. Okay. Not even because sometimes we do it for the mother. Okay, because we fear that if the mother is negative and the child and the fetus is positive, that's where the problem comes. So negative mother to a positive fetus, we are going to have a problem. Hemolysis, agglutination. I don't want that to happen. All right. So we have to prepare immune globulin afterwards to give. All right. So that's what you should know. Do you please understand? Do you understand?
Yes, please.
All right. So another thing is that, so with this amniocentesis, please, these two things, I'm repeating, don't forget. Blood type, RH status, and the fetal heart rate. Don't forget it as your priority. All right. And as a nurse, as I was saying, you need to witness the signature. Okay. Do you have to obtain an informed consent? Do you have to make sure the patient signs?
Yes, please.
Yes.
So you verify if it was obtained. You verify if the informed consent was obtained. All right. Witness the signature. Okay. Don't explain. Is it your duty to explain the procedure to the patient?
No, please. No. It's the surgeon.
Okay. So just know that. All right. And this one should be sterile. It should be sterile because we are passing a needle through someone's abdomen to the what's the name? To the amniotic fluid. And number one thing that we fear is what? Chorioamnio what? Nitis. Infection. Okay. We fear that. Or even sometimes endometritis. All right. We don't want to cause that. So that's what you should know. And it can lead to pregnancy loss. Because if this agglutination occurs, you know what is going to happen. Can lead to infection, as I was mentioning. Leakage of amniotic fluid through the vagina. Okay, so once again, you should also assess. So if you see any signs of maybe signs of infection, what do you do? Signs of infection, what do you do? We report. Because note that we report complication. We report complications. So anything that is complication, signs of complication, signs of pregnancy loss, signs of fluid leakage, and you're going to see it in what? The vagina. So you have to know that the patient having wet perineum. Okay, note that. Are you going to have we are going to have preterm baby. It can lead to preterm labor. So what do? You assess if there's what? Contraction. Do you understand? You assess if there's contraction, if there's back pain. Because if there's back pain, there's contraction, it's a sign of what? Contraction. All right? We have to also know that it can cause sensitization, RH sensitization, that's agglutination, okay? And you have to report leakage. You have to report if there's contraction. You have to report if there's severe abdominal pain. It's a sign. All these things are signs of what? Labor, okay? Or decreased fetal movement. That is a sign of what? Pregnancy loss. Okay? I'm not feeling the child or the fetal movement. Report. It's a complication. I please, okay.
Yes, boss.
All right. And chorionic villus sampling. Okay. Chorionic villus sampling. This thing is also an invasive.
Bra Frank,
Yes, please.
please, I just want to find out. You see the anti-D, for resource negative mothers, they take it like twice during pregnancy. I just want to find out that if they have taken the two and there is a need for this amniocentesis to be done, do they have to take the anti-D again?
All right. That's a good question. But I want to ask you to answer your question, or for the class to answer your question. I want to ask this counter question. Is it good?
Yes,
Is it good?
boss. Yes.
All right.
And those of us like myself that we take the anti-D, we said with the amniocentesis, it's performed within the 15 to 20 weeks. And by that time, you've not taken the ROGAM. The ROGAM, your first dose is being given at 28 weeks. So, as Boss Frank was saying, if you are anti-negative mother who is supposed to be given ROGAM, and you are going to undergo this procedure, I think it should be given just to prevent any complications.
Okay.
All right.
And please, I have a second question. I've ever witnessed somebody so this person didn't know the husband was resource positive. So she got pregnant, and then along the line, the pregnancy was aborted because of this anti-D issue. The mother was resource negative. If something like that should happen, if she happens to get pregnant again, do they have to give the ROGAM early in the pregnancy, or it still has to wait until the 28 weeks, as she explained? Thank you.
All right. So that's a good question. Anti-D is given in pregnancy, is given, as our sister Eva said, at when? At when? 28 weeks.
8 weeks.
And when again?
32.
And when again? You said?
32.
No.
Within
Birth,
7
after birth.
Giving
After
birth.
birth.
72 hours.
Within
72 hours
72
after birth.
hours after birth.
Yeah.
Within 72 hours after birth. And not only that, if there's abortion, you have to give. If there's miscarriage, anything that will cause blood mixes. Are you okay? So
Yes, it makes a lot of sense. Thank you.
yes, I hope it's answered. Can you go on?
Frank,
Yes, please.
the reason why I said 32 with my twin gestation, I was given 28, 32, and right after delivery. So how come did they give the 32? Is it because it was twin gestation or what? Can you explain it for me?
They gave what program?
Yeah. I was given 3 times.
Given 3
28,
times.
32, and right after delivery. Yeah.
Okay. So the point is that ideally, okay, ideally, it should be 20 weeks gestation. Okay, as a routine prophylaxis, and should be given after delivery. Okay, but and let me add this, and addition that those additional situation that happens like miscarriage, maybe patient is having ectopic pregnancy, if there's hemorrhage, if there's stillbirth and those stuff. Okay, it should be given. But to give program 32 weeks is not the routine thing that we do. That's not the routine. I don't know why they gave at 32. I don't know the reason why. But
Hospital.
that the
Okay,
routine thing
boss.
that we do, ideally, or the standard one is 28 and 72 within 72 hours after delivery.
Okay, boss. Okay.
Someone was adding up.
She said it might be a hospital protocol.
Okay.
I don't know whether I heard it yet.
Yes. Maybe. Or I don't know what happened. But the first one, was it effective? Was it given like correctly?
Yes, please.
With no issues?
No issues.
All right. So as you said, but the standard one that we know is 28 and what's the name?
That after delivery.
Yes, and other special situations like miscarriage and those stuff. Sister Star.
Thank you.
Yeah, Boss Frank.
Yes, please.
Yeah, good evening from here. Please, I wanted more clarification about the question our sister asked about the mother who didn't know the husband was rhesus negative. According to her, the woman miscarried. So in this case, if the program was not given, and then she comes back with another pregnancy, do we have to give?
Anytime you are pregnant, you still need it.
So do we wait till the 28 weeks before?
That's the protocol.
Okay.
All right.
Okay. All right. Thank you.
Mm-hmm. So anytime you are pregnant, anytime you have to give. So within 28 and then 72 hours after birth, you have to give.
That is if she didn't even receive any in the first pregnancy.
Yes.
Won't it have any effect on her subsequent ones?
I easily the first pregnancy can be saved because that's during delivery. That's where the blood must mix. Okay, and that is when the mother is going to develop the antibody, waiting for the next pregnancy.
Okay. Okay.
Do you understand? So
yes,
the first pregnancy is always safe.
Okay.
And the mother will develop the antibodies subsequently, waiting for the subsequent pregnancy.
Oh, okay. Okay.
Do you understand?
Yes, please. The subsequent one, the 28 weeks is what I'm scared of. As to if the fetus will stay till then.
The fetus will do what? Yeah.
Like
No
till the
problem.
20.
Yeah. The fetus will wait for you, okay?
Okay.
Don't worry.
Hello,
Thank you.
Bonjour.
We wait for you.
Hello, sir.
All right.
Hello, sir.
Yes, please. A question?
Yes, sir. I'm hearing about the husband being rhesus negative. I've never known that the husband's blood group has an effect on the baby like that.
Oh, I'm sorry. I think our colleague said the husband was positive and the pregnant woman, was negative. That was the mix-up, yes.
Okay, because when I heard it, I've been thinking about that. I've never, all right. If that's the case, it's okay. I heard the opposite.
Okay. All right. So I hope we can move on, right?
Yes, sir.
But please, I have a question.
All right.
Yeah, please, after the amniocentesis, so between assessing for bleeding and the fetal heart rate, please, which one takes priority?
Assessing for bleeding and fetal heart rate.
Yes.
Bleeding is not when bleeding comes. Okay. One thing is that we are not afraid of the mother developing hypotension. That's not our focus. Do you understand? Our focus is the mother have developed, especially if the mother is negative, developing this antibody against the fetal blood. Do you understand? So this one, we always go in for the fetal deceleration. Because fetal deceleration is as a result of what? Oxygen. Are you okay? Hello?
Yes, please.
Right.
Yes, please.
All right.
Thank you.
Okay. So we can continue.
Please, I have a question.
All right.
So this, I don't know whether you've said it earlier because the voice keeps breaking at my end. This procedure, is it a routine procedure? Because in Ghana, I'm not sure every pregnant woman undergoes this procedure.
Which
If
one, please?
The amniocentesis, what account for this procedure? Is it that if they are suspecting something that they do this procedure or what?
I've already talked about the indication. If there is possibility, we are doing genetic or chromosomal disorders. We are suspected. Okay. We want to know if there's a neural tube defect. Okay. And those at high risk, that's what we do for them. It's not a routine thing that we do.
Okay, thank you.
Do you understand? It's not something routine. You want to, if there's suspicion, or maybe if the mother has already given birth to a fetus with genetic disorder. Okay. So those at high risk, we have to do it for them. You understand? All right. Thank you all. So let's do with the coronary loss sampling. And this thing, as I said, this one also is an invasive procedure. Okay. And this one, we are looking at okay, the amniocentesis, we are taking fluid from where? The amniotic fluid. And then the amniotic fluid contains the genetic makeup of the fetus. And it also contains the lung function. Okay. And with this one, coronary villus sampling, we are looking at what? Performing it, taking a sample from where? The placental tissue. Chorionic villus, the villus, the colon. Okay. So this one, we are looking at the placenta, taking sample from the placenta tissues. That's the chorionic villus. Okay. And this one, it goes in for the same thing, with the exception of yes, the first one. Look at it. Neural tube defects. It doesn't, because neural tube defects, for neural, the spinal bifida and anencephaly, it has to do with the fluid that the child or the baby is lying. Okay, because the spinal cord and the whole body is lying in the fluid. So that one, it makes sense when you are doing it for neural tube defects. But you can't take chorionic villus sampling to just to assess for neural tube defects. No. So we can do it for what's the name? Chromosomal analysis. We can do it for genetic analysis, but not for neural tube. Neural tube has to do the fluid that the baby or the fetus is lying in. Okay, and this one, it goes in with the same thing. We have to it requires informed consent. Okay, we evaluate the status of the mother. We assess the heart rate afterwards because you are looking at the chorionic, which is the placenta. We're looking at oxygen. So fetal heart rate after procedure is one of the priorities. Okay, and this one can lead to miscarriage, bleeding, because we are looking at taking a sample. All right, it can cause a rupture of the membrane as well as what? Limb defect. But know that this is mostly performed earlier than amniocentesis. Okay, this one is chorionic. You are looking at the placenta. So sometimes the placenta comes earlier. Okay, with the amniocentesis, you need to get enough this thing to fluid, amniotic fluid to do the sample. So with the chorionic villus sampling, it just 10 to 13 weeks gestation. We can do that. All right, this one is earlier, always comes earlier before doing amniocentesis. Do you please understand?
Yes, boss.
All right. All right. So that is that for this thing. So next time we are going to deal with ectopic pregnancy. Okay. So just prepare for ectopic pregnancy tomorrow, God willing. All right. Any question? Any questions so far?
So, but Frank, so
Yeah.
is this one also used to detect the Down syndromes and the trisomy 18?
Yes. Just genetic and chromosomal analysis.
Okay.
Only neural tube defects. Only neural tube. So that is, and the neural tube, we are looking at what? Spinal bifida and what?
And I
The
can't find.
brain. When you look at the spinal cord, we are looking at the spinal cord and the brain. So the neural tube, we're looking at the spinal cord and the brain. So spinal bifida and what? Anencephaly. That's you having a small brain. Okay. So that's what we assess. Apart from that, the trisomy 13, 18, the Down syndrome, the Turner syndrome, Klinefelter syndrome, those syndrome, we can assess for that. Okay. So it assesses genetic and chromosomal analysis, but not for neural tube. Neural tube is what the baby is lying in. That's the fluid, not the placenta. I please okay.
Yes, boss.
And know that this can lead to limb defects. The limb of the baby. Okay. Either the upper or the lower limb defect because of the colonic villus sampling. Okay. It can lead to limb defects. Very, very important. Please take note of that. Okay. Because for miscarriage, for vaginal bleeding, is obvious that we can easily know that. But limb defect is one of the commonest complication of chorionic villus sampling. Okay, and know that this comes before amniocentesis. Amniocentesis is just half of the gestation period. That's 15 to 20. How? And this one is 10 to 13 weeks. We can just do it for genetic. But if you want to do neural tube, so know that sometimes the question can be asked like within the 10 and 13 weeks, can you detect neural tube defects? with chorionic blood sampling? Can you do
No.
that?
No.
No.
Should be the baby should be around what? 15, 16
To
to 20
20.
weeks before can do neural tube defect. That can diagnose that. Okay. So as simple as that. All right. So know that this one too, you have to do the same assessment. Heart rate and what's the name? RH status. Very, very important. Very, very important. Okay. You shouldn't forget. Okay. So if you haven't what's the name? Chorionic blood sampling. Okay. We have to know that these things are very, very essential. The RH, fetal heart rate, before and after. So know the timing. Okay. Know what the procedure is about, because sometimes they can ask you, so what are you going to tell the mother? So know that it's an invasive procedure. And this thing can be done either trans-abdominally or trans-cervically. So trans-cervical, or you can do it just pass through the cervix, okay, or through the abdomen, like you doing amniocentesis. Okay, so that's what you should do. So just take a small sample from the placenta tissues. All right, you just take a small sample from the placenta tissue. All right. So that's what you have to do. So if you are going to do it trans-abdominally, do you think it's necessary for the mother to empty the what's the name?
The
The
bladder.
bladder?
Yes, because it's an
Yes.
invasive procedure.
Yes. All right. So that is what you should know. So this one also has to do with ultrasound guidance. All right. So that is what you should know. But sometimes after the procedure, because we are looking at placenta, and that's where blood, the fetus gets blood. So once we punch it, we pass a needle, we sometimes have to educate the mother to rest for about 24 hours. Please take note of that. The mother should rest for about 24 hours because we are looking at puncturing the placenta and the possibility of bleeding. We have to let the mother rest for at least 24 hours. Okay. So if the mother has to do with heavy lifting, you're a guy and you want to chop your wife, no sexual activity. Do you understand? So this thing too, if you are looking at, if there's any, you report the complication. So if there's any fever, you know that it's infection. If there's any fluid leakage from the vagina, okay, or from the abdomen, if there's maybe severe abdominal cramping, the mother is at risk of what? Miscarriage. All right. Or the fetus is not moving. All right. This is at mean that the mother is out at risk. All right. And know your program that the mother should expect being given what program after this test. Do you understand, please?
Yes, boss.
All right.
But John, please, I have a question.
Yes, please.
I was just thinking something is bothering me right now. With autism, I know it's a neurodevelopmental disorder, but if amniocentesis can detect Down syndrome, can't it also help us to detect autism at early stage so that it can be treated too?
That's you want to detect
whether a child will be autism, can that procedure also help us detect when a child or a baby will develop autism?
Okay. Autism know that it's what's the name? It's a neurodevelopmental condition. Do you understand? Do you understand?
Yes, boss.
Mhm. So if what's the name? If we are doing the chorionic villus sampling, okay, with chorionic villus sampling and amniocentesis, what are we detecting? Genetic disorder. And this one is not a genetic disorder. It's a neurodevelopmental, although genetic plays a role, okay, but it's not a genetic disorder. Do you understand, please?
Yes, boss.
So know the genetic disorders. If you are having cystic fibrosis, it's a genetic disorder. If you are having sickle cell, it's a genetic disorder. It's recessive, all right? So those genetic disorders, we can do what? Chorionic villus sampling or amniocentesis to detect, but not neurodevelopmental conditions.
Oh, okay. But that one to genetics can cause
Which one?
the autism.
Yes, as I said, genetic plays a role. Genetic plays a role, but it's not a genetic disorder.
Okay.
Do you understand?
Yes, boss. Thank you.
So that's what you should know. Any question, please? Any question? So, okay, I can see a question here. How can this thing cause limb defect? Any answer? Yes. Hello.
Is it so? Does it have to do with injury to the sciatic nerve?
Sciatic nerve. No, most of the times, when
Yeah.
it all has to do with blood, because we are looking at what's the name? We are looking at the colon, okay, the placenta, and the placenta has to do with what? Blood, isn't it?
Yes.
Yes. And you know, this thing, as I said, when do we do it? When do we do CVS? When do
10
you
to
do that?
13 weeks.
So you see that it's too early. All right. The child, just 10 weeks, the child is now developing. Okay. And this one, we're going into the placenta. Do you understand? So we can cause injury to what? To the blood supply. Okay. And mostly if, let's say, the blood that is supplying the limb, okay, if the blood is supplying the limb, the right limb or the upper limb or the lower limb, and you cause an injury to that blood supply, that blood vessel, can't it cause or lead to this? Because, and most especially, it can lead to this if it is done too early. Because the child has not fully grown well, and any little, and they rely mostly on the blood supply. So any little disruption to the blood flow can have effect. All right. So most especially if it's done early. I know CVS mostly done 10 to 13 weeks. The child is not growing enough. It's just a bud that's in the uterus. You understand, please? So that is what you should know. Are you okay? All right. We are saying that when there is implantation occurring outside the uterine cavity. Okay, and most especially with ectopic pregnancy, it occurs in the what? Fallopian tube. All right. So as a nurse, we have to know what are some of the common risk factors that can predispose a person to getting this condition pregnancy. All right. So when we have previous experience of ectopic pregnancy, definitely you are at risk. Okay. And some of the infections that we have can also predispose pregnant women to have ectopic pregnancy. For example, if you have PID, okay, and chlamydia, gonorrhea history, they are all infection that occur. All right. So if you have this infectious condition, they can predispose you to get this condition, ectopic pregnancy. Okay. And we also have tubal surgery. The tube, the fallopian tube, if you've done a surgery on it before, all right, sometimes it becomes constrictive. Okay. And because of the scars around that area, it becomes very difficult for the ovum to travel into the placenta. Into the uterus. All right. And IUD use. Okay, if this one is this the family planning. Okay, intrauterine device. All right. So if we implanted intrauterine device, sometimes it can be difficult. Where is the ovum or the fertilized ovum coming to implant? Okay, because this one sits directly in the uterus. Okay, so it can prevent the fertilized ovum to implants in the uterus. All right, and endometriosis. Okay, endometriosis, we are looking at where there's a change in the cells. Okay, the cells of the uterus, when there's a similar cells growing elsewhere, for example, in the fallopian tube, all right, it becomes a ground for this fertilized ovum to just implant, because it just sees it as the normal uterus, not knowing it just the cells, okay, of the uterus growing elsewhere. All right. I hope you understand.
Yes, please.
Okay. So if someone is having ectopic pregnancy, there are two things to know for the sake of English. Either it is ruptured or not ruptured. And what are the signs and symptoms that we can see if it is ruptured or if not ruptured? For ectopic pregnancy, please don't forget these two things: ruptured and unruptured. All right. So usually we have lower abdominal pain, because look at where the fallopian tube is and look at the structure. When we compare it to the uterus, it is quite smaller than the uterus. Okay, I mean the surface. So if the ovum is just growing, all right, and not having space to occupy, it put pressure on the ovaries, on the tube. Okay, so will sometimes have what? Lower abdominal pain or pelvic pain. So when you are pregnant and you are seeing lower abdominal pain or pelvic pain, you have to also do another investigations. Okay, you are getting what? Amenorrhea. Okay, sometimes you have menses coming, sometimes it's not coming. All right, or sometimes you see spotting. You see spotting of blood coming through the orifice. Okay, so or sometimes it becomes dark brown. The bleeding becomes dark brown. It's like the what's the name? The uterus is shedding what? The one that is prepared for implantation. Okay, so sometimes this is what you are going to see. But if it becomes late or ruptured, what happens? There's a rupture, and when it ruptures into the uterus, into the abdominal cavity. Okay, so sometimes patient will have severe what? Sudden abdominal pain. Usually, you are going to have abdominal pains, lower abdominal pains. But when it becomes so severe and sudden, that is the term, severe and sudden, it tells you that there's a rupture. Okay. And when blood is collecting in the abdomen, okay, it's just going to push the diaphragm upwards, and sometimes patient will have referred pain. Okay. From the what? Diaphragm due to internal bleeding. So when patient is bleeding internally, you're going to put pressure on the diaphragm, and breathing becomes a bit difficult, referring pain to the what? To the shoulders. All right. And once the patient is bleeding, obviously there's going to be hypotension. Okay. With hypotension, you're going to have reflex tachycardia. So hypotension, when patient is bleeding, the heart has to come in to compensate. All right. And patient will experience pallor, dizziness, syncope. All these things are signs of what? Shock. All right. So you are going to experience signs of shock together with sudden severe abdominal pain, referring to what? To the shoulders. Okay. And when we are having internal bleeding, note this. We have a sign called Cullen sign. That's the umbilicus. So when we have like ecchymotic blue abdomen, because when blood is when you are bleeding inside, okay, you look at your abdomen, look around the especially the umbilicus. Okay, you see that place is like there's blood collected under the skin, ecchymosis. Okay, and now you see sometimes, especially with fair people, you see it to be what? To be blue colored. All right. So when we have ecchymotic, that's blood collecting under the skin and appearing bluish. Okay, that is what we call it, the Cullen sign. So we have, once we see Cullen sign, it tells you that patient is bleeding internally. Cullen, that's blood collecting in the internal organ, internal cavity, that's abdomen. Okay, and you see this color usually around the umbilicus. Okay, so once you see it around the umbilicus, it becomes a Cullen sign. All right, Cullen sign. That's ecchymotic blue abdomen, and that is as a result of what? Bleeding internally. Are you okay, please? So know the signs of ruptured ectopic pregnancy. That is something which is sudden and most common in the English. All right. So how are you going to diagnose? When you are pregnant, we have what we call HCG. What's the full meaning of HCG?
Human
chronic
Okay. All right. So the human chronic gonadotropin, this one is going to what? Elevate. Okay. That's human chorionic gonadotropin. All right. This usually, when women are pregnant, if they want to see if they are pregnant, they just go and collect urine, okay, and test. What did they test? That's the hormone, okay, HCG. All right. So once you are pregnant, obviously there's going to be an increase in the HCG. All right. So when you check for HCG, don't assume that the pregnancy is not in the uterus, so HCG is not going to go up. All right. And we can do transvaginal ultrasound. So once you go in transvaginally, Are you going to see any sac in there?
No.
No, because the implantation is not occurring in the uterus. So there won't be no sac, no gestational sac in the uterus when you do transvaginal ultrasound. Okay. And once, if bleeding is occurring, patient will obviously experience what? A decrease in hemoglobin as well as what? Hematocrit, which would be an indication of what? Bleeding. So once patient is bleeding, please check for hemoglobin. A decrease in hemoglobin as well as what? Hematocrit. All right. But if patient is not bleeding, just like ectopic, patient not bleeding, this one will not be indicated. The only thing that will know that patient is having ruptured uterus, ruptured ectopic, is when patient is having what?
Shoulder pain.
Yes, starting abdominal what? Severe pain, referring to the shoulders. So once patient is having these symptoms, then you can request for hemoglobin hematocrit. And that's where you are going to see that there's a decrease of these labs. All right. So how are you going to care? And with ruptured, we assume the patient is what? Unstable. Once there's a rupture, we need a quick intervention. So that one is not about giving fluids, it's not about whatever. That's not your priority. Your priority is to prepare, because once it's an emergency, you have to prepare the patient for emergency surgery. Okay. And that is what? Sapingectomy. Okay. That is what we are going to do. Sapingectomy. Ectomy is just the removal. Okay. Gotomy is just what? What is it? Yes. What's the difference between sapingectomy and sapingotomy?
Otomy is creation of an opening.
Ladies first. So, our lady, please stop. What did he say? Yes. Is it there?
The fallopian tube will be opened.
Okay.
Ectopic be removed.
Yes. So that's it. Okay. So once there's bleeding, there's rupture, you need an IV line. And that one is not, we're not going to use 24 gauge. We're not going to use 26. We're going to use what? 18, 20, ideally. And whenever there's bleeding, they assume that your IV lines should be at least 2. Okay, IV lines should be at least 2 whenever there's ongoing severe bleeding. All right, and always start with what? Large bore IVs. Okay, know the type of the patient blood. Okay, cross-match blood, because when there is emergency, patient can bleed, and unless you place the blood. Okay, so when patient is unstable, which is ruptured ectopic, the patient is seen to be what? Unstable, and emergency treatment needs to be what? Used. That is by preparing the patient for what? Emergency surgery. That's your priority. Okay, not medication. All right. And one thing is that whenever patient is having ectopic pregnancy, we can, because there is pain, because we said that there is what? Lower abdominal or pelvic pain in ectopic pregnancy. Lower abdominal pelvic pain, because the growing fetus is just exerting pressure on the tube. All right. And once there is pain, definitely you are going to give pain med, isn't it? But one thing is that with ectopic pregnancy, please take note, we never give any analgesic stronger than acetaminophen. Are you okay? Because an example is what? Opioids. We don't give opioids. Why? When there's a rupture, one thing that will indicate that there's a rupture is what? Sudden severe abdominal pain. But when you are giving opioid, it's going to mask this symptom, this essential symptom that will help us to know that there is a rupture. So we never go beyond acetaminophen. Okay? We don't want to mask the signs of rupture. And that's the cardinal sign, which is what? Sudden severe abdominal pain. Don't want to mask by giving anything stronger than acetaminophen. So that's what you should take notes. Okay. If the patient is stable, means there's no rupture. Once the patient is stable, means that there's no rupture. What are you going to do? Are you going to see that we are not going to do surgery now? Supposing that we are not going to do a surgery now. How do we do away with a child or with a fetus? We have to what? Prevent growing. When there's no rupture, please take note. When there's rupture, there's no way we are going to prevent growing. We have to do emergency surgery. But once the fetus is there, we have to prevent growing in order not to reach rupture stage. Okay, so what do? We give what we call methotrexate. And methotrexate, is an where else do we use it?
Rheumatic fever.
Yes. So
Cancers. They also use in cancer.
It's also used in what?
Cancers.
Cancers. Very good. It's an
In chemotherapy.
Yeah, chemotherapy. Yes, very good. So with methotrexate, we use it in ectopic pregnancy, but only when it is not what? Ruptured. You don't want to let it grow. And one thing is that while you are pregnant, you go in for ANC, and we always give you what we call folic acid, isn't it? And with this folic acid helps with the growth. Okay? Helps with the growth. And one thing is that once we are suppressing growth, are you going to give folic acid?
Never.
Never. So it means that whenever someone is taking methotrexate in ectopic pregnancy, please don't give folic acid. You don't want to do any counter management. You are suppressing growth. At the same time, you want to give medication to help growth. No. So know that methotrexate and folic acid, they are enemies to each other. Are you okay? Okay. Is that proceed? All right. So that is what you should know. Okay. We are looking at methotrexate. And the main purpose is to stop cell division. Take note. That's what I said. It stops cell division from dividing. And when cells are not dividing, it means there's no growth. Okay. And so that once cells stop dividing, this tissue there, that's the ovum, the fertilized ovum there, the tissue will what? Reabsorb. And then the pregnancy will go away. So that's the ideal management. We mostly give methotrexate, and then it will stop dividing the cells, and the pregnancy will be absorbed, and you'll be free.
Hello.
Okay. Yes. Someone else?
Hello.
Yes, please.
Okay, so meaning if there's no rupture, so we want to get rid of the pregnancy.
If there's no rupture, yes. Because we want to get rid, because there's no way please mute up for us, okay? Thank you. So there's no way the fetus can grow well, can be viable in the fallopian tube. There's no way. That's not its usual place. It has not enough space to accommodate that. All right. It needs to be in the in the uterus. And once it's there, once fertilization has taken place and implantation has already taken place, it means that it has implanted into the what? The walls of the tube. And there's no way it's going to get into the uterus. So we have to get rid of it. If not ruptured. Mr. Franklin.
Boss Frank.
Yes, please.
Please, I'm getting confused between the rupturing of the ectopic pregnancy, because I know that when rupturing occurs, one sign is that the patient will suddenly report absence of pain. So I'm getting confused when you said there will be the pain will increase. So I don't know. You can explain that.
The patient will get absence of pain in ruptured ectopic pregnancy?
No. There is severe
No.
pain.
Oh, there is severe pain.
No. We shouldn't.
There will be severe pain. It is an peptic ulcer. Sorry.
Placenta previa. That's why we have painless.
We are not dealing with this thing. What's the name? This condition, abdominal condition. What is it?
Appendicitis.
Appendicitis. Appendix. When there's appendiceal rupture, do you have pain?
No.
Do you have pain in appendiceal rupture? Yes.
No.
There is no pain.
All right. So please, we should be very careful with conditions so that it doesn't become so many and like unorganized in our brain. Okay, we should just organize the conditions in the brain. Okay, so that once we see the condition, we know that's the sign. That's how to manage. Okay, so Mr. Frank, there's pain, severe pain. All right, there's severe sudden pain.
Oh, okay.
All right. So
like severe.
Very severe. And that's what we don't want to mask it when there's rupture by giving opioids. Okay, that's our goal. When it's not ruptured, please, we want to stop cell division, and at the same time, we don't want to mask the pain so much that we wouldn't know if there's a rupture. So that's what you should know. All right. So we give methotrexate when patient is hemodynamically stable. All right. When there is no rupture, when we are having low HCG levels, and when there's no fetal cardiac activity. All right. So that is when we begin to give methotrexate. So when patient is hemodynamically unstable, we don't go in for methotrexate. Unless patient is stable hemodynamically. And when it is not ruptured, we can give. But once it's ruptured, it becomes an abdominal thing. And there wouldn't be any need for methotrexate. Please, okay. So,
yes, please.
Thing that we should consider is that if you want to know methotrexate is working, because once the pregnancy is there, there's going to be an increase in the HCG, the human chorionic gonadotropin. So once you are given this medication, methotrexate, and cell division is like you are stopping cell division, it means that the levels of HCG should rather come down. I hope you understand that.
Yes.
Yes. So if you are given this medication, you should be monitoring what? Your HCG levels until it becomes undetectable. Like you see 0, you're not seeing any rise or any HCG there again. Please take note, because that is an indication that methotrexate is working. Okay, and even after treatment, we have to continue to monitor HCG levels, and we avoid alcohol. We avoid folic acid because it's a folic acid antagonist. Okay, and avoid pregnancy for at least, because it's a cancer drug. So you should avoid pregnancy for at least 3 months after its use. All right? And you have to monitor liver function. All right? Know the BUN, because you are dealing with the kidneys. The kidneys is going to excrete this medication. It's a cancer drug. So know your creatinine levels, because once the kidney is eliminating this drug, we know we are safe. But if not, that means it's going to develop what? And we have to know our CBC, all right? Monitor for sudden pain. So once you are giving, you have to monitor for sudden pain. Sudden pain, once there's sudden pain, it tells you that there's rupture. And you have to stop this medication. All right, so monitor these drugs. You don't give to patient who is taking folic acid. So once you are taking it, you have to avoid folic acid, avoid alcohol, monitor your kidney as well as your liver. Very, very essential. Okay, and monitor for if there's sudden pain, and you should avoid it within 3 months after its use. All right, that's what you should know. And our main goal is to whether there is a reduction in what? HCG. So weekly HCG checks is essential, so that once you know that every week I'm going to check for my level of HCG and it's down, you know that this medication is working. All right. And mild one is expected, but severe one, there's a rupture. Okay, that one we have to report. But mild cramping is expected after this drug. Okay, but once there's a rupture, please, you don't use it.
But Frank,
Kidney, because yes, please.
please, how long do we take the medication?
For the medication, if you are taking methotrexate, know that our main goal is to do what?
Reduce HCG, clear off the pregnancy.
Okay. So once you are giving this drug, okay, know that we are reducing the cell division. All right. So what we have to know is that we have to take it mostly once within 1 week, it should leave the system. Okay, within 1 week. All right, we should have what's the name? You should have the cells should what? You should stop cell division. So if you are taking what's the name? Methotrexate. Okay, but most thing that they do is we take it once. Okay.
But Frank.
But yes, please.
Please, is it an injection or a tab? I've seen the injection before, but I'm not sure if there are tabs for that.
Yes, there is.
Okay, so in the case where there is unruptured ectopic, we give the patient tablets for its injection, or is according to the HCP's discretion?
So what they usually do is that once we give you one, we have to watch, be monitoring your HCG levels. Okay, because once we see that it's coming down till it becomes undetectable, that's when we are fully assured that there's pregnancy loss now. I place okay. So once we give you first one, we monitor. If not, okay, and then we give you another one. But these drugs, we don't give like today we give, tomorrow we give. No, because it's a cancer drug, we don't want to be given continuously. So sometimes they alternate the days. So we give you today, and tomorrow can have free day. Okay, and the next day we can give the medication to you.
But that will come from the HCP, whether it's an IV, a tablet, and the days the patients will be taking the medication, right?
That's the treatment is the same. Treatment is the same. Do you understand?
I want to know if they will be giving IVs, like IM, or it is tablets they take home.
No, they don't take home because we are monitoring. So, and that's
Sure.
initial stage. You have to be at the hospital and give.
Oh,
Okay. Mostly,
okay,
so
okay,
maybe IM they give. All right, IM medication they give,
okay,
but we have to be at the hospital because we want to see if there's no rupture, because that's
okay,
what we highest priority that we are preventing.
okay.
So we have to
I
be
understand
admitted
now.
and be at the hospital and give you today, and the next day we check, you monitor the levels. The following day, if it's still high or it's still not dropping, then we give another dose. So we give alternatively sometimes till maybe 4 days or 4 times or 3 times, and then they have to be monitoring your distance, the HCG. Are you okay, please?
Okay. Yes, please, I am.
All right. So, and even after the treatment, I said that they monitor it what? Weekly after the treatment. After the treatment, we still monitor HCG, not only during the treatment.
No.
Please take note. Not only during, but after treatment, we still have to monitor this HCG till when? Zero. It's undetectable. Not even low. Not even low levels. 0, 1, 0. Undetectable. Are you please okay?
Yes.
All right.
Boss.
Yes,
Sir,
yes.
please, I have a question.
All right. Please go ahead.
Okay, sir.
Okay,
I'm
thank
a bit when the HCG gets to 0, I'm just curious, what happens to the remains of the baby? I don't know if you said it and I did not hear.
The remains of
The fetus, the implanted
Absorb into the tissue, reabsorb into the
read the
tissue.
first one. Purpose: stop cell division, pregnancy tissues. What?
Reabsorb.
Okay.
Are you answered?
Yes, sir. So it means that there's only a particular level to which the pregnancy can exist. If its tissues can be reabsorbed, like this is just a particular level to which the growing fetus can form.
I don't understand your question, please. Come again.
Like if it can be reabsorbed, it means it's just there's just a particular limit to which the pregnancy can progress.
You know that with
Or it will rupture.
yes, because it's in the tube, and the tube it doesn't have enough space to contain the fetus. Okay, it's very narrow area. So if it's growing, so that's why sometimes we have an indication, like we have spotting. You are pregnant, but you're having menses. Okay, sometimes your menses will come. Go and check. Don't just assume to be normal. You're having spotting of blood, and you are there. You're having maybe small lower abdominal pain, and you are there. No. Go and check. Don't assume to be a normal sign of pregnancy. It could be more than that. Are you please okay? So
Yes,
when
okay.
it goes to a certain limit where the tube cannot no longer contain, then rupture comes in.
Okay, sir. Thank you.
Are you please okay?
Yes, sir. I'm okay.
All right. So methotrexate, liver, what? Kidney, folic acid, alcohol, no. And avoid pregnancy for at least 3 months. Very, very important. Not 1 month. 3 months. For at least 3 months. Very, very important because it's a cancer drug. All right. All right. So, how do we prevent?
Boss,
Yes, please.
to ask
Your line is
my
breaking.
question when my sister came in. Please, ideally, let's even say that a pregnant woman with a cancer is contraindicated because probably it could go a long way to also maybe cause stop cell division in the uterus, even if the implantation takes place in the uterus, right? Or that is not the case.
Hello, please.
Hello.
You said it's contraindicated in where?
I mean, the medicine, the methotrexate, is it indirectly also contraindicated in normal pregnancy where implantation takes place in the uterus? For instance, maybe a woman or a pregnant woman with cancer cannot take it whilst pregnant, or that shouldn't be the case.
Yes, it's highly contraindicated. Okay, anything that is teratogenic is contraindicated in pregnancy. Okay, so methotrexate is contraindicated. And I hope you know metimazole.
Yeah.
Which is used to treat what?
Thyroid.
Yes. You know that one can be also teratogenic, right? So we don't, those medications, we don't use them when you are pregnant. All right. As well, last what? Even warfarin, right? Okay. So,
But
it's
yeah, I said was Frank. Sorry.
Yes.
Please, I'm just curious. You stated some contraindications for methotrexate when a patient. So for the ruptured ectopic, I know the patient will go into surgery. If you monitor the liver function test or the kidney function test, or the patient is breastfeeding, how do you get rid of their unruptured ectopic?
When the woman is breastfeeding.
Yes, or there is a problem with their liver function or kidney function. How do you get rid of their unruptured ectopic pregnancy?
Okay. So, who can answer her, please? Yes.
So I think that if you are breastfeeding, if the problem is breastfeeding, you have to stop breastfeeding.
Okay. And what about if patient is having liver or kidney condition?
Will they go into surgery?
Surgery?
Yes.
So, what you should know is that, okay, with methotrexate is the first line treatment of unruptured ectopic pregnancy. But we only give this medication on some certain conditions. And one, we said if the patient is what? Hemodynamically what? Stable.
Stable.
All right. We are having unruptured ectopic pregnancy. Okay. If the cardiac there's no cardiac activity, no distance before you give methotrexate. Okay, so that's when you should know. But if you are giving, if patient is, let's say, breastfeeding or having liver conditions or any other thing, obviously they can go in for what? Surgery. Okay, but know that surgery is mostly reserved for what? Ruptured. Okay, ruptured. Or when the contraindications of methotrexate is what? Available. It's like when patient is hemodynamically unstable. Okay. That one we have to go in for said. Okay, so we prepare you, and when you are hemodynamically unstable, the patient is there's rupture, you have to prepare you for said. So, but know that methotrexate is first line treatment. Very good.
Okay.
You understand?
Yes, please, I do. Thank you.
All right. I hope we can continue. Hey, Mr. Delight, I think you wanted to ask a question.
Yeah, I wanted to ask a question which was very similar to what my sister asked. That's why I lowered my hand.
Okay, Sister Delight. Sorry. All right. Thank you so much. All right. I hope we can go on, all right?
Yeah.
Okay. So, how do you prevent this? We said that clients who have ectopic pregnancy, they are at risk of what? Miscarriage from methotrexate use. So once you use methotrexate, you are at risk of what? Miscarriage. All right. And RH isoimmunization, what we learned yesterday. Because we said that apart from those who are at high risk, that when we give it on 28 weeks and within 72 hours after birth, if there are other additional conditions like this condition, okay, miscarriage and those stuff, once there's rupture, once there's bleeding, once we are doing amniocentesis, once we are doing chorionic villus what? Sampling. But once there's a rupture, you know that we have to do what? RH isoimmunization. There's possibility of isoimmunization. Okay, so know that once there's rupture, there's possibility of blood mixing. Okay, so we have to do what? Give what? Rogam. I hope you're okay. And we need to also prevent pregnancy until the HCG is undetectable. All right. And avoid intercourse and contraceptive use for at least 3 menstrual cycles, which is equivalent to what? 3 months. It's simple. Okay. So this thing, even if there's surgery or even with the drug, you have to still avoid what? Pregnancy for 3 months. Very important. So don't go and do the do. Okay. Oh, yes, please.
Please, with the do no. You are advised to, you can do it, but you have to use.
Yes.
You have to protect
contraceptives.
yourself.
What is the do? What is the do?
Like the sex, no, the sexual intercourse, no.
Yes.
You have to protect yourself from getting pregnant.
Yes. So the two of them. So either you avoid it or use contraceptives.
Yes,
if you can. But you shouldn't get pregnant for 3 cycles. All right. And if the mother is RH negative, what do? We administer the program. But note that if the mother, although there's blood missing in miscarriage, blood missing in ectopic, but note that if the mother is not negative, you're not going to administer, right?
Yeah.
Unless the mother is negative. That's where we are going to administer this program to prevent sensitization, immunization. Okay, that's what you have to know. If not, subsequent pregnancies, you are going to experience hemolytic disease of the fetus. And high drops will also come in. All right? Okay. Let's move forward. Oh, I think, okay. All right. So one thing that you have to know, unruptured means that the patient is stable. We use methotrexate. All right. Ruptured, ectopic, patient is unstable. There's shock, surgery, emergency. All right. Severe abdominal pain. It means that you have to what? Assess for rupture. When patient is experiencing this, assess for rupture and notify your provider, prepare for surgery. Patient taking NSAIDs. Okay. We teach to stop the drug and use what? Acetaminophen. We said we don't go beyond acetaminophen in ectopic. And when after methotrexate there's rising HCG, it means that there's treatment failure. So know that treatment failure, because that's what we are doing. We are giving methotrexate to stop cell division so that the pregnancy tissues can be reabsorbed. So if you are getting high levels of HCG after methotrexate use, that is a strong indication that the methotrexate did not work. All right? So that is what you should know. All right. So this thing we have already talked about yesterday, right? Fetal monitoring. Okay, we are done with ectopic. No question, right? We are moving on to fetal monitoring. Fetal monitoring, we are looking at baseline, variability, acceleration, deceleration, uterine activity. Baseline, variability, accelerations, decelerations, uterine activity. That's what we are looking at. Okay. And know the normal baseline fetal heart rate is what? 110, 160. Less than 110 means brady. Above 160, tachycardia. All right? And we use external monitors. Okay? Non-invasive monitoring. Okay? We place it on the mother's abdomen. Okay? Especially on the what? At where?
Where the fetal heart rate
can be what? Heard. That is the fundus. Okay? Where the fetal heart rate can be heard most. All right? And we use Doppler. All right? In this one, we use they fasten a belt around the mother's abdomen. Okay? And that one measures the fetal heart rate. Okay? It uses Lipper's maneuver. Okay? That is, they will use ultrasound is placed over the fetal back. All right, where it can be heard most. The fetal heart rate can be heard most. That's the Lippert maneuver that they use to place the ultrasound transducer. It's a transducer that would convert the sound, okay, into heart, so that it can be viewed on the monitor. All right, and they use tocodynamic dynamometer. That's the toco. And that one is placed over the fundus, and that one measures contraction. All right, as we saw yesterday, it measures contraction where it can be contraction is what strongest at the fundus. All right, that's what you have to do. And with contraction, we measure the frequency of contraction and duration. What is the difference between frequency and duration?
frequency is the contraction comes, and for how long does it last?
Okay, how long it lasts is the duration, right?
Yeah.
And the count is frequency. That's maternity terms. Right. Thank you so much, sister. So with this one, Always when you are doing fetal monitoring, please never place your patient in supine. Never place them in supine. Okay. So that's what you should take note. We want to avoid supine hypotension. All right.
Boss Frank, I have a question.
So, a client present with
Boss Frank.
for 7 weeks. All right, please. Please go ahead, okay? Hello.
Please, on the regular, I just want to know if it's wrong.
Which
Yes.
one?
Please, can you hear me?
Yes, we can hear you, please.
I'm asking a question.
All
That on
right.
the regular, when you go to AAC in Ghana here, you will be made to lie on your side. But when they are coming to check your baby's FHR, they will tell you to lie on your back. So the lying on the back, is it wrong? For the
Either
brief period that they want to check the
if they do it in fowler's position, semi-fowler's position, but back supine, you flat on the bed, it's wrong.
Okay. Thank you.
For supine, just flat on the bed, because that's number one thing that we fear most is what? Getting what? Orthostatic what? Sorry, supine what?
Supine hypotension. But that's what they do, as my sister is saying.
We don't do that. Okay.
But they're very small pillow.
you raise the bed small. Okay, the head end small. All right. So in semi-fowler's position is okay, but flat, sometimes they can do it for about more than 10 minutes. They are still checking or doing their own thing. It's bad. We don't do that. All right. So a client present with amenorrhea for 7 weeks. Okay, 7 weeks amenorrhea. Unilateral pelvic pain, unilateral. And that one is telling you that patient is having what?
Ectopic.
One-sided.
One-sided, yeah. That's the fetus is just at the right or left. And light vaginal bleeding, spotting, which findings most strongly indicate an ectopic rather than early intrauterine pregnancy. So we want clinical indications solely for ectopic, not early pregnancy. So select order to apply. All right. It says that beta HCG levels of 2,200 with an empty uterus on transvaginal ultrasound. B, progesterone levels of 2. Closed cervical os, nasal tenderness on pelvic organ, passage of products of conception, history of tubal surgery. Yes, let's select and move on.
A.
I'm not Bozia, but just left.
Yes, but Frank, I keep confusing you. Sorry. A.
Don't worry.
A.
All right.
And F. At least I think these two.
Those who can talk, please let me see your charts.
F. I'll go for A and F.
A, history, PCD levels with empty uterus on transvaginal ultrasound. F, history of tubal surgery.
And then D.
Yes. I'll choose A, C, and F.
A,
C.
C, closed cervical os, and what?
History of tuber surgery.
History of tuber surgery. Okay.
Yeah, ACF.
All right.
ACF.
D for
A C E F.
So we don't have closed cervical os in early pregnancy. We only have it in ectopic. Is that your answer?
Is C is part to say?
C is part.
Of course.
So we are saying that we only have closed cervical os in only ectopic.
I think the question is not clear to some of this. Yeah.
No, I think the closed cervical os is
Will be
mostly
a normal
observed in placenta
pregnancy.
previa.
Yes.
Because
I think
previa
the
is
question is asking us to it should not be. I think
Yes.
closed cervical os is here and there. So something that strongly indicates that that should be present in only ectopic pregnancy is what Boss Frank is asking.
Exactly.
Yes.
Only
So it means C is out.
ectopic.
There is
That's the
D
question.
tenderness. Where I mean that on palpation you feel pain.
Yes. So D should be part.
So ADF.
ADF. Tenderness of pelvic. All right.
And F history of tubal surgery.
History
Tubal
of
surgery probably. Yes, it means that maybe the tubes are not there. So I don't think F should be part.
indication of ectopic. Mostly it's
F
an
should.
when you have history of tubal surgery, does it mean that you have ectopic pregnancy?
No.
It indicates, which indicates you're not looking at risk factors.
But yes, that's just
Me, I'm choosing only A.
Already a topic pregnancy. So what will really make us to know that truly it's a topic rupture, a topic? I'm sure that's what the question is
So I'll choose A and D.
A and F.
A and F.
A and D.
So D, nasal tenderness from pelvic.
D is part. Yes, I think D is part.
Do you know nasal tenderness on pelvic exam? Who has done this? If you've gone for ultrasound before, and they tell you that we are having nasal tenderness, have you experienced that before? Who has experienced that before, or seen a colleague experience that before?
Hello, Mr. Frank.
Yes, please.
Yeah, I think I'll go for ADEF.
AD.
Yeah,
Passage of
ADF.
products of
ADEF.
conception.
Yeah, that's the answer. That's what I'll go for. Thank you.
Passage of product of conception. So when you are passing product of conception, does it indicate ectopic?
No.
No, please.
No, that's more of a miscarriage, Anna.
Miscarriage.
Yeah, that's
And that's spontaneous abortion.
Maybe.
I think what the question is asking for is that strictly what signs are
Ectopic.
in the options
Classical sign
provided.
of. Then was Frank, the A and D there is part two. They are classical sign of ectopic.
Yes,
Yes, aside A and D, I don't think any other is.
Okay. Why are you eliminating progesterone?
I'll add
Just
B.
because some of us don't
Because
know
in
the normal.
ectopic pregnancy, Boss Frank,
Yes, please.
please, I'll add. It's pretty. I'll add B to it because in ectopic pregnancies you have low progesterone rates because of because the pregnancy is not viable.
Okay.
I don't know how to. Yeah. So for me, I'll go for A, B, D, and F.
A,
B, D,
D.
and F. As in D for dog.
Okay. Why F?
Yeah. Because you made mention, maybe I didn't hear you right, but because you said, it's a risk factor of a person having another ectopic pregnancy after the person has gone for a tubal surgery.
Yes, but the
But you
question
said risk factor is not part, so
which findings most strongly indicates an ectopic pregnancy?
then it's A and D.
I'll stick to A because of that word strongly or most strongly. Because the other ones are like, yes, they can be answers, but that word most strongly points to A for me. And
If strongly, then I'll go for A, B, and D.
Okay,
If
so
strongly, I'll
obviously,
go for A, B, and D.
History or HG level of 2 with empty uterus. Yes, that is correct. Okay. Progesterone levels of 2. It indicates to you that this because when there's pregnancy, early pregnancy, progesterone levels, will it go down or up?
It should go up.
Okay. So it should go up. All right.
Yeah.
Enclosed cervical os and nasal
So
tenderness of
please is B part.
B. Okay, B is part. Because if the pregnancy is viable, you should experience an increase in progesterone.
Progesterone. So low progesterone causes miscarriage. So yeah, you should have a higher progesterone level of 20 and above in first trimester.
Sure.
So less than 20, as in 2 here, can cause that.
Yes, so progesterone is obviously part. All right.
Yeah.
And nasal tenderness on pelvic exam. Yes, that's an indication that you are having ectopic pregnancy, isn't it?
Yes.
Yes, so it doesn't indicate that you are having early intrauterine pregnancy. With early intrauterine pregnancy, doesn't present with nasal tenderness on pelvic exam. Okay. Passage of products of conception. If you are early pregnancy ectopic, it doesn't present with product of conception passing through. No.
The one is miscarriage.
Unless there's miscarriage. History of tubal surgery. This one, we are looking at one that will indicate that patient is having ectopic. And when you have tubal surgery, it doesn't indicate that you have ectopic. It's a risk factor, but it doesn't indicate that you are having what? Ectopic. Do you understand?
Yes, sir.
So the final answers are A, B, and D.
So I was correct to the second option.
A, B, and D. Okay. A, B, D. All right.
Please, what is the normal progesterone level?
What's the normal progesterone level?
Yes, also I found out it's 10 to 44 during the first trimester, and then 19.5 to 82.5 during the second trimester, and then 65 to 290 during the third trimester.
So it increases. All right.
Please come again.
That is why people with low progesterones are supported with the artificial ones in pregnancy to avoid miscarriages.
Sure.
Sometimes. Yeah.
Yeah.
Are you okay?
Yeah. I was frank with the progesterone level of 2. No, I know that low progesterone level indicates a abnormal pregnancy or like failing of the pregnancy. So that one, I don't understand why it's a cardinal sign of ectopic pregnancy.
I think our sister explained it in a simple way.
Yeah, I heard it, but I still don't.
Pregnancy, yes. So, sister, come again. Maybe she didn't hear you. What did you say? Where is
I
she?
said, please come here. So I said non-viable pregnancies normally come with low progesterone levels. So anything less than 20 indicates a severe low progesterone. So seeing 2 here means the patient is at risk of having a miscarriage or an ectopic pregnancy.
It's not
So it means
viable.
Yeah, it's not viable. There is no viable pregnancy. So the progesterone is not increasing as it's supposed to be.
All right.
Sister Eva, please, you understand now.
Yes, please.
Can you just come with the normal levels of progesterone for the trimester?
Sister Prissy, she wants you to come again, or?
So we agree that the answers are A, B, and what?
A, B, and
D.
Okay.
Mr. Frank.
Yes, please.
I still have an issue with the B.
B.
Yes, please.
What is it?
Because for your question, you were saying indications of ectopic pregnancy, right? As our sister rightly said, instances of where the pregnancy is not viable, that one is still in the uterus, all right. It's just that it's not viable. So this one with the B, it doesn't clearly, to me, I think still it's not clear like that because I don't know.
That was what I wanted to find out. It's not a cardinal sign of ectopic
I still
because
have, I don't know if you can
less
explain better
progesterone
because
level is abnormal. It's abnormal pregnancy or when pregnancy is failing. They all have progesterone levels being low.
yes.
So I don't know why it's a cardinal sign for ectopic.
Yes.
We are not saying
That's
it's a
why I'm
cardinal
saying
sign.
that
Listen,
because
listen to the question. Listen to the question. The
yes.
question says that it's just comparing ectopic and intrauterine pregnancy. Okay, ectopic and intrauterine pregnancy. That's what is making a comparison. So, if the one that is solely, you can see it in ectopic. You can see it. This one can see that. I can tell you that because with all these things, if you do transvaginal ultrasound, it will tell you that patient is having and then there's no empty uterus. It tells you the patient is having, it's a possibility of what? Ectopic. And with adnexal tenderness on pelvic exam, okay, unless you do scan, do further test, okay, it doesn't rightly tell you that the patient is having ectopic. But when you compare it to this question, the question at hand, when you compare ectopic with intrauterine pregnancy, we are looking at things that ectopic pregnancy can present with. Do you understand? So if patient is having what's the name? Progesterone levels of 2, okay, know that ectopic, okay, progesterone is not something that we can base on it to diagnose that patient is having ectopic pregnancy. The same thing with adnexal tenderness on pelvic exam. Okay, it could be a whole lot. When patient is having adnexal tenderness on pelvic exam, it could be patient is having ovarian cyst. It could be that patient is having pelvic inflammatory disease. It could be that. Unless we do a more what do you call it, examination. The same thing with progesterone levels. Once the uterus, what's the name? The fetus is not in the uterus.
Non-viable.
Non-viable. It can present with low levels of progesterone. But note that it alone is not something that we can base on solely to diagnose that patient is having. But when you compare it to with this condition, ectopic and intrauterine, know that ectopic will always present with progesterone low progesterone levels. Do you understand? Because,
yes, please, Mr. Frank.
Yes. So that is basically that. Okay. Because know that with this with what's the name? With progesterone levels, what produces progesterone? The corpus luteum, right? So once there is viable pregnancy, the corpus luteum will still continue to produce progesterone just to maintain the endometrium. But once it's not there, and you are seeing low levels of it, it tells you that there's something else, which can be ectopic pregnancy and not early pregnancy. Do you please understand?
Yes, boss.
Okay. All right. Which finding indicates treatment failure after methotrexate? Abdominal pain on day 3. The ACG drop of 10% by day 7. Rising beta ACG levels after day 4. Nausea and oral ulcers. Mild vaginal spotting.
C.
What?
C.
C.
Yes.
All right, this one is obvious. Do you understand, please?
Yes, please.
Okay. A client asked, did I do something to cause this ectopic pregnancy? Which response is best? This happens because of poor lifestyle choices. You should have come earlier. Most ectopic pregnancies are due to tubal factors beyond your control. Stress is the major cause. It won't happen again.
C.
What?
C.
C. All right. This is quite obvious. All right. So we are looking at fetal monitoring, fetal heart rate monitoring. As we've already talked about, we are looking at these things: baseline variability, acceleration, deceleration, uterine activity. That's what we are going to look into. And I think we have an internal, we can monitor the heart rate internally. Okay, we can do external monitoring as well. All right, so that is what you should know. Can do both internal and external monitoring of fetal heart rate. And each, you know that with internal, it comes with a risk. Okay. And use when we are doing external monitoring, and external monitoring is inaccurate. You are not seeing accurate result of external monitoring. Then the best way is to do internal fetal heart rate monitoring, especially in obesity. The abdomen is so big that with the once you wrap the belt around the transducer around the abdomen, you cannot, because if you are using the leopard maneuver, you're not able to assess where exactly the heart rate is, the back of the patient is, or where the heart rate can be heard most. All right. So, and because of that, or if you are having frequent movement, it's an indication that your fetal external monitoring will be inaccurate. So we have to go in for internal monitoring. All right. But it's invasive, and that one increases the risk of infection. because we are doing transvaginal. All right. And this one, know that we can perform when after membranes have ruptured. If the membranes are intact, why are you going to place the electrodes on the fetal head? I hope you understand that. So, if the membranes are intact, we can't do it. Unless the membranes are ruptured and the head is exposed, that we can do it. And we have to have dilation, cervical dilation. If cervical dilation is less than 2 cm, you can't do monitoring. You have to get the head of the fetus to what? Monitor. So if dilation is less than 2 and fetal membranes are intact, you can't do it. Okay. And this one, with bridge presentation, we can't do it because we need the head. So vectors presentation is the best way to do it. All right. And fetal heart rate is measured using the fetal scalp or electrodes. So they place electrodes and we call it fetal scalp electrode. We attach it to the fetal scalp. That's why the name is attached, fetal scalp electrodes. All right. And we measure the frequency, duration, and intensity of contraction are also measured. And that one uses what? An intrauterine pressure catheter. Okay. So that's what the internal monitoring is all about. Okay. But if you are doing this and patient is HIV positive, okay, or the mother is having active herpes simplex infection, okay, at that place, when there's herpes simplex,
that place.
okay, yes, we can do it. All right. So that's what you should know. And with variability, we've already talked about all these things. So we're just brushing on, then you go. We are looking at bit-to-bit fluctuations. Every bit, because if you get 120, that's why sometimes once you are monitoring the heart rate, it keeps fluctuating. 130, 131, 182, 130, 114, something like that. It keeps fluctuating. So that is what we call variability, bit-to-bit fluctuations. Okay. And that one, it tells you that yesterday I told you that it can be the same 130, 130, 130. If there's variability, it's good. And that indicates fetal well-being. The fetus is receiving enough oxygen. And it tells you that there's enough fetal oxygenation and the nervous system is actively working because the blood is supplying the nervous system with enough oxygen and blood. And that one will help the heart rate to change bit per bit. All right. And when we are seeing this, we say it is what? Reassuring. It's good. Okay. It tells you that the fetus is good. All right. When it is not reassuring, and that one require intrauterine resuscitation. While the baby is there, we can resuscitate. And know that we have also amplitude.
So, how we
Yes,
resuscitate in utero?
Pardon?
How can we resuscitate in utero when the baby is still in the uterus?
Okay, that's simple. Yes, class. How do we resuscitate?
Oxygenation to the mother.
The mother, through the mother.
And what else can we do?
Is it Ringer's lactate administration?
Lactate, fluid administration. Yes, it's good. Positioning is good. All right, that's resuscitation you are talking about, not CPR. Okay. All right. So that's what we are doing. And we have variability. Okay, yesterday I think I told you. We have absence. That we are looking at the amplitude. I think yesterday I showed you, right? Let me show you. this thing. I'm coming. I think yesterday I showed you. Okay. All right. Up, you've seen this one. Have you seen it?
Yeah, we did this last week.
Okay. You've seen the flat line where my arrow is showing, right? Have you seen the flat line?
Yeah.
There's no variability. There's no change in heart rate. It's just flat. Okay. And this one is minimal. You can see the minimal. Just small change in the heart rate and then come to the baseline. Just small change. This one is what? Moderate. Okay. And that one is good. And this one marked very high, peaked ones. All right. So, and I said with the minimal, you see 1 to 5 beats, moderate, which one is good, which is between 6 and 25, and marked beyond 25. Okay, I think we did this last time. All right. So, and I told you that if it's absent, no change, flat line, that one is non-reassuring. And that one will indicate that maybe there's severe hypoxia or acidosis. Okay, because hypoxia leads to what? Acidosis. Okay, respiratory acidosis. All right. So if there's acidosis or hypoxia, it becomes absent or severe one. We have minimal, that's less than 5 or 1 to 5. Okay. And we have moderate. Okay. So if it's 1 to 5 or less than 5, it tells you that maybe the mother is sleeping, the baby is sleeping, or you have given mark salt medication, all right, or there's mild hypoxia, all right. And moderate, that one is good. You have to keep on monitoring, document is good. That's normal, that's reassuring. And marked very high means that there's acute stress or hypoxia. It's like having very high heart rate. When you are stressed, when you are anxious, your heart rate goes very high, isn't it? The same thing. So when the heart rate is going high, it means that the fetus is in acute stress. Okay? Or there's lack of oxygen. Because once there's lack of oxygen, your heart rate will be pumping. The heart will be pumping more, it needs more oxygen to the cells. So that one is what happens mostly. And when we have a temporal decrease, less than 30 minutes in variability, okay, it can occur during sleep. Once you are sleeping, we can have a decrease in heart rate. That's normal. But know that moderate variability is the gold standard. That's the normal thing. All right. I hope you understand that, please.
Yes, boss.
Yes. So as you can see, all right, you can see the mark, very high, peaked ones, goes up, down, moderate, okay, minimal, flat, absent, all right. And we have accelerations. This one is a temporary increase in the heart rate. And that is once 15 at least, okay, more than the baseline. So once we are having a baseline of, let's say, 130, the heart rate is 130. And then once in a while, the heart rate goes up to 140, 150. More than 15, or at least 15, it goes up. That's okay. And if it lasts at least for 15 seconds, it goes up and then it comes back to normal. That's normal. Acceleration is okay. Okay, and that reassuring sign, it reflects what? The fetus is responsive. Once it hears something, then heart rate goes up. It's responsive. It tells you that the fetus is non-acidotic, no acidosis. Okay, And this one, once the child moves, it occurs with it. It's a normal thing that occurs with movement. Okay, and that is reassuring no intervention is needed. All right. So we've seen the baseline heart rate is, let's say, 120. So where the blue arrow is, okay, that's where they always fall. So that's the baseline heart rate, 120. All right. And the down one represents what? Fetal contraction. Maternal contraction. Okay, the down arrows. Okay, so you can see a hill here, and then goes up, down, and then you can see that one is contraction. And then the one on top is what? The heart rate of the fetus. And as you can see, it comes with numbers. So each line represents 10. Okay, 10 beats apart. All right. And then from longitudinal ones represent the minutes. The vertical ones represent the heart rate in terms of the change in the heart rate, the numbers. All right. That's what you should know. Okay. So if the heart rate, I hope you can see the acceleration at the middle. So see that the heart rate was around 120, and just here, it went up and came back to normal. That is acceleration. And that's good. And then it came back hovering around 120. That's the baseline. And that's okay. And variability, as we said, we can see a change. It goes up, down, goes up, down, goes up, down, and it comes back to the normal. Not below it. When it is below the this thing, that's not what we're talking about. But it goes up, hovering around the baseline. Okay, that's variability. And you want moderate variability. That's the change should be around 6 to 25 bit change. Okay, if it's going up, you go as high as 25, more than 25. So if the heart rate is 130 and goes 25, which is 155, and suddenly it comes back, that's normal. But if it goes beyond 25 and sustain for, that one is not good. That's marked variability, and that one represents acidosis, or the fetus is in severe distress. All right. Do you understand, please?
Yes, boss.
Yesterday we talked about this, so this one is not something that's. All right. So we are looking at duration. We want to take duration as our sister explained. Okay. From the beginning to the of contraction to the end. That's the duration. So when you take the first maternal contraction here, where it started, okay, and then it rose up, it rose, okay, up, and came down, and it came down and rested. That's the duration. That's the duration that you are to.
Mama,
end
what
of
is
contraction is the duration. All right. And frequency is the beginning of one contraction to the beginning of the next one.
Mama?
Hello, please try to mute up. Sister Nikki. So that is what you should know. And we are saying that if there's a transient decrease in fetal heart rate below the baseline, usually associated with what? Uterine contraction. That is deceleration. So deceleration is a decrease in the fetal heart rate below the baseline. So when we have the baseline to be 120 and it falls below it, that is deceleration. Going up is acceleration. So with deceleration, I've already explained to you the types. The early, variable, and what? Variable and what? The late. Early decel, I told you that we take fetal birth. Okay, the head comes first, the umbilicus, and then the placenta last. The head of the fetus, when we are delivering, the head of the fetus comes first. Then the umbilicus comes second, and placenta will come last. So when we have early deceleration, whenever there's contraction, and contraction compresses the head of the fetus, the heart rate will go down. That is early deceleration. Once contraction stops or ceases, then the heart rate will pick up again. And that is deceleration. So when there's a fetal head compression, the heart rate comes down, that's early decel. And there's no problem. Okay, that's no problem. And that one, as I showed you yesterday, it mirrors contraction. Once contraction comes in, that's the same time that you are seeing a drop in heart rate. Okay, as normal finding, just keep on monitoring, keep on documenting. All right, we have late. Late is what comes last. And when you take the head, the placenta, and then the cord, the placenta will come last when we are delivering. So placenta is the late decel. And late decel is placenta. The cause is placental insufficiency. And what will cause the placenta to be insufficient? When there's decreased what? Blood flow. All right? That's when we call placenta insufficiency. When there's decreased blood flow through the placenta to the fetus. That's what we call placenta insufficiency. And what can cause that? Okay. And when we have maternal hypertension, there's maternal hypertension. The blood pressure is too low. How can it supply enough blood to the fetus? Through the placenta. Preeclampsia, there's severe contraction, hypertension. Okay. It means that the vessels are constricted, decreased blood flow to the placenta. You're also going to have placental insufficiency. Diabetes, you know this thing is the sister is what? Hypertension. Post-term pregnancy. When with post-term, the placenta is gradually detaching. Okay, because it's beyond the term. So post-term, once placenta gets detaching slowly, where will the baby receive blood? Excessive uterine contraction. That's why when there's oxytocin infusion, and you see that the heart rate is decelerating, quickly you have to what? Stop the drug, because oxytocin infusion can act like what? Constricting the blood vessels. It's like patient having hypertension or preeclampsia. The blood vessels are constricted, decreasing blood supply to the fetus. Okay, so oxytocin hype or overstimulation, the same thing. All right, so these things can be as cause of what? Placental insufficiency. So once you see placental insufficiency, it means that that is the number one cause of late deceleration. All right, and late deceleration means that it came what? Late. The heart rate drop late. That's it occurs after the what? The contraction. It means that contraction will come, and once contraction is ceasing, that's when the heart rate stop what? The heart rate start going down. It means that contraction came first, heart rate decrease second or later. That's why we call it late decel. Contraction always comes first, and once contraction stops, then you see the heart rate going down. Because once there's contraction, it's going to decrease what? Cause blood vessel constriction. So once contraction ceases, then you see the heart rate dropping. Because ideally, if contraction ceases, the blood vessels should dilate to supply blood to the fetus. But this thing, late deceleration, contraction has ceased, but the fetus is not getting oxygen. That's a problem. This one, we have to quickly intervene. All right? And how do you intervene, Lion? Left lateral, increase IV, fluids, oxygen, 8 to 10. We are not looking at nasal prawns. We are looking at non-rebreather, not nasal prawns issue. All right? We have to resuscitate. You have to notify your provider. That's the most important thing. So once you are experiencing this, quickly, you have to place the patient in a left lateral position. If the patient is on fluids, you just have to increase. That's the resuscitation. Okay. And we may have bradycardia. All right. Bradycardia, if we are having. So let me ask you, what would be the difference between bradycardia and deceleration? Bradycardia and deceleration. Yes, who can help me? Bradycardia and deceleration.
Let me try.
Okay.
So bradycardia is when the fetal heart rate is lower than the normal range, and the normal range is 110 to 160. So if it's below 110, it means that there is a bradycardia or fetal bradycardia. But with deceleration, there could be a normal heart rate, and then out of maybe contraction or placental insufficiency. So it depends if it's early or late. There will be a decrease in the heart rate, and it can drop as much as 15 beats per minute.
Okay. Thank you so much. Any other? Your sister Ramaya, you heard it okay? All right. Any other? Yes, please. Sister Prissy. Is Sister Prissy around?
What's Frank?
Can you help us?
Please.
No.
Hmm?
I'm sorry. Let me see.
Bradycardia is when the fetal heart rate is less than 110, lasting for 10 minutes or more.
Mm-hmm.
And the decel, like the decel, we have to do deceleration. So for early decel, the heart rates remain greater than 100. Although it drops below 110, but it doesn't go less than 100.
Okay.
And then late decel, it can go less than 100.
Okay. All right. So that's what our sister is helping us. All right. So mostly know the normal heart rate. And when we are having bradycardia, okay, that means bradycardia should last at least for more than 10 minutes. Deceleration, as I said, is a temporal thing. Temporal. So deceleration means that this one we are getting less than 10 minutes, and then once if there's hypertension or whatever, once we intervene it goes. But with bradycardia, if it's lasting for more than 10 minutes, all right, and that is what we, and this one mostly bradycardia, if there's sometimes it changes around the baseline. Okay, you have the baseline to be 130, and then we're having maybe below the 130, and then it comes back. All right. But with deceleration, that one, it doesn't change the baseline. Okay, and this one, deceleration lasts less than 10 minutes. Okay, but bradycardia, if you're having bradycardia heart rate less than more than 10 minutes, that one too is a concerning, isn't it? It's concerning. All right, which can be as a result of hypoxia, maternal hypotension, or there's cord compression. Okay, and know that cord compression will cause what? Ideally, cord compression will cause what? What type of acceleration? Deceleration.
Variable.
So I'm hearing late.
Variable deceleration.
Okay, variable. I said this thing is simple. When we look at the fetus, we have the head. That one comes first in normal delivery. The head comes first. The umbilicus comes middle or second. and the placenta always comes last. So early, we are looking at the head. So once you see early deceleration, you are looking at the head compression. And that one is what? Normal. True or false? True or false?
True.
You have to intervene.
True.
You have to intervene.
No.
It's
No.
normal. Once compression goes,
Normal.
and the middle, what comes in the middle? The cord.
The cord.
So once we are having variable is the middle. When you have variable deceleration, okay, that one is cord compression. And the last one is the placenta. So when we have late, last one come last, late. So late decel is placenta. Variable called early head, as simple as that. All right. So you know that apart from early, variable and late, are they good or bad? Are they good or bad?
Bad.
They are bad. Okay. So when you have variable decel, late decel, they are not good. You have to intervene. Okay. So same as if the mother and the fetus is having bradycardia, you have to intervene. You have to know what's causing that and intervene. Okay. All right. So yesterday, I think I showed you this. All right. Early, the first, you can see the blue hill, okay? And you can see the red line or the pink up. Always, the down one represent what? Maternal what? Contraction. And the up one represent fetal heart rate. So the first one, when you see contraction going up, you see that that's the same time the heart rate is declining, coming down. That is early. So it mirrors at the same time, early decel. This one, the middle one is the late. Know that heart rate decrease late after contraction. So contraction is always first. So once contraction ends and you see the heart rate going down, it means that it came late. And that is what? Late decel. And that is a cause of what? Placental insufficiency. And variable, you can see that this one, it has no pattern. It can decrease, increase at any point in time. It doesn't go with contraction. It can decrease when there's contraction. It can decrease when there's no contraction. So that's variable. All right. So basically, that is that. So when you have variable decel, that's what abrupt. So know that this relation is just abrupt decrease. Okay, less than 10 minutes. Okay. And the cause, as we've established, is cord. Nuchal cord. Okay, so when the fetus has nuchal cord, okay, that's the cord around neck. That's what we call nuchal cord. All right. So it's a cord problem. Variable decel is a cord problem. Okay, so example is what? Cord prolapse. So cord prolapse will cause variable decel. It won't cause late decel. It won't cause early decel. Okay, oligo. Yesterday I told you, because once there's oligo, if the baby is moving in the uterus, it can have cord around neck or can have nuchal cord. So oligo can cause variable decel. Okay, and fetal movement squeezing the cord or maternal position sometimes can compress the cord. So these are some of the what was the name? Variable causes of what? Cord, umbilical cord compression. All right. So if patient is having oligo, sometimes you can give you can introduce fluid, isn't it? Hello?
Yes, sir.
Do you understand, please?
Yes.
Okay. So that is what you should know. All right. So, with this one, it can happen before doing a variable. So it doesn't go with contraction. It can happen before contraction, during contraction, or after contraction. So the shape is irregular, as we saw. Okay. And drop occurs in less than 30 seconds. Okay. So decrease of greater or equal to 15 bits lasting for, and you know this cell, yesterday I told you. This cell, 15. Okay. So when a decrease of greater or equal to 15 bits per minute. So if let's say is the baseline is 120 and a decrease of 15. So which will be what? 50 minus 120 will be what? 105, right?
Right.
And if it lasts, that decrease lasts for at least more than 15 seconds, but it will last maybe for at least 2 minutes. That is a D cell, variable D cell. Okay, so once we are having all these things, what would be the intervention? What would be the intervention? Yes? What would be the intervention?
Surgical operation.
Operation. Okay. Any other?
So I think there's where maybe position 2 would have to come in, placing the mother also in left lateral position.
Okay. Any other?
Knee chest position.
Knee chest position. Okay. Any other? All right. So as we are saying, this thing, we are looking at compression. The cord is being compressed. All right. And that one is resulting in this. As we said, it could be that maternal position can be a factor. All right. We can have nuchal cord. We can have oligo. All right. The fluid is so small that once the baby turns, it's going to have cord around neck. All right. These things can be as part of. And once it happens like that, there's going to be abrupt drop in what? The heart rate. And this thing, as we said, can occur before, during, and after. All right. So one thing that you should know is that reposition the mother. Reposition the mother. Okay. Where someone also suggested knee chest. Yes, can do knee chest. So knee chest position, assuming the mother is having cord prolapse. I hope you understand knee chest position. You know how it looks like, right? Cord prolapse. It means that the cord has
Before.
Yes, has come earlier than the head. So once you open the vagina, what are you going to see first? The cord. And once the cord has come, the head is going to compress because it's the same orifice that the head is going to pass through. So once the head, the fetus, the umbilicus has come, the head is going to compress it, and the heart rate is going to decrease. Okay, so what do we do? In that instant, what do you do?
Position the mother, chest position.
Position the mother. Okay. So our focus here is to relieve the pressure on the what?
On the cord.
So position by niches. I hope you know niches. How does it look like?
The knees will.
He said,
You are putting your knees down, then your buttocks is like going up. Then your stomach is like reaching, going to the bed. I don't know.
okay. Okay. Something like the common thing that you know, sorry for this, it's like doggy.
Doggy, yeah.
So if it happens like that, once you see that there's cord, please don't go and push the head back. Don't go and push the cord back. All right. Always get a sterile glove. Okay. Or sterile gauze. Okay. And with maybe, which is soap, isn't it? And you wrap around it and try and push the head, not the cord. All right. So knee chest is good, and lateral position too is good. So we do it to relieve the cord. All right. So that's what you should do. And if there's oxytocin ongoing, you have to stop oxytocin. If there's fluid, you give fluid. Oxygen, you give. Then lie on. Okay. So you check if there's cord collapse. So once you have seen that on the monitor, the child is having variable D cell, what do? You assess for what? No, I'm saying if you see on the monitor that the child is having variable D cell, what do you do? What do you do first?
You assess for cord compression.
Yes, that's the word. You assess for cord compression. If there's cord prolapse, you assess. Okay. If there's nuchal cord, you assess. So once you see variable D cell, you do assessment. Your baby first.
If I may ask, so I was thinking that what these measures are temporal measures, and the final measure to take intervention is surgery. Why? Because I believe that after why putting this woman on this knee chest position is just to relieve the cord, proper circulation while they prepare for surgery. Because I thought that the best intervention is surgery, because it's an irreversible thing. I don't think that for that woman will be in that position for long, or when they push the head back, everything will be fine, that woman will assume her normal activities again. I don't know, if I may ask.
All right. So as we were saying, all right, if the mother, we are having cord prolapse, definitely the most appropriate action is to do surgery.
Okay.
All right, the most appropriate. You can't let the mother push. Pushing will complicate. So that's why even we are stopping oxytocin. All right, but our priority here is to just relieve cord compression before surgery.
Okay.
You understand? Before surgery, our priority is to relieve the cord compression, because if you don't relieve, the child will die.
Yeah.
All right. So that's what you should know. All right. Any question before we close? Or any addition? All right. So that's what,
please, I have a question. Please, with the contractions within the 90 seconds, please, what duration is the best one? It keeps confusing me. Thank you.
Contraction as in, I don't understand the question.
Like, the contractions that the woman should be within that seconds to, like maybe two, I don't know how to put it all.
One contraction is 5 minutes.
Yeah, that one. That one.
I didn't. The voice was low. I didn't hear it well.
Boss man, please, I wanted you to help me with the contractions within that 90 seconds. That 90 seconds, which is like normal, the best one.
So the normal contraction.
Mm-hmm.
All right. Please, someone is writing on a screen. Please. All right. So one thing is that when you take contraction pattern, okay, it has a pattern. And that one would depend on the stage of labor that the patient, the mother is. Okay. I hope you understand that. Because you have to know, maybe I didn't understand your question, but if I understood your question, it depends on the term of labor. Okay. If, let's say, the mother is having when there's early labor, okay, or the mother is in active stage, or depends when the mother is in transition stage. Is that what you are talking about?
Yes. Yes, please.
Okay. Yes. So you know the early stages of labor. Okay. The frequency, it takes a longer time before every contraction. Because when you are about delivering, the time of delivering, that's where contraction is going to be quite frequent. But when you are starting, it takes some time before it goes off. Okay, sometimes it can take as long as 30 minutes. Okay, when you reach the transition phase where the frequency is so fast, that's where sometimes within 2 to 3 minutes there's contraction. Within 2 to 3 minutes there's contraction, and that is what we call the frequency. I hope you understand. That's what we call frequency. Or I'm lying. Enough frequency. The midwives.
Yes, please.
That's the frequency, right? So it maybe 2 minutes. There's every 2 minutes there's contraction. Meaning that is the transition phase of labor. All right. And we have what we call the duration. Duration is how long it lasts. Okay. But contraction should not exceed 90 minutes. 90 seconds, right? It shouldn't exceed 90 seconds because as we've already established, if there's contraction, it's going to compress. Either we are going to have placental insufficiency, either we are going to have cord prolapse, variable deceleration, or we are going to have what? Early decel. All of them will decrease blood flow to the fetus.
That one is precipitate level.
Pardon?
Precipitate level.
Yes.
When the contraction is so frequent.
Happens so quick. Within seconds, then there's delivery. 4 hours, 3 hours, there's delivery. That's precipitous labor. All right. But over here, know that we shouldn't have contraction more than 90. Ideally, it should be 1 minute duration. That's the approximation. 1 minute duration. That's 60 seconds. I please okay. That is, you should have at least 60 seconds of contraction. So once contraction starts, 160 to within 1 minute, you still experience contraction. That's the normal thing. But if it is and getting to 90 and beyond, it's abnormal. You have to maybe if there's oxytocin on, okay, we have to stop the oxytocin. And if there's fluid, because the baby is going to lack oxygen, going to lack fluid. So you have to give fluid and report the case to your healthcare provider.
Okay, boss. So it's 2 to 3 within 90 seconds, right?
2 to what?
2 to 3 minutes within 90 seconds.
No, 2 to 3 minutes is like every 2 minutes or every 3 minutes, there's contraction. That's about delivery.
Okay.
So when it becomes, the frequency is so close, that means you are nearing delivery. So that is the most of the time the transition phase. Okay, that's where you are transitioning from labor to delivery. So that time the frequency should be so quick. Every 2 minutes it should, because that is helping to push the baby out. Because if it delays, the baby is going to die out of what? Air hunger. So that phase of labor, frequency should be so quick. Comes 2 minutes. Every 2 minutes, there's contraction. Every 2 minutes, there's contraction. And then it lasts longer. Okay. And as I said, it shouldn't be more than the 90. And if it lasts more than 90, that's where the problem lies. That the fetus is going to die out of oxygen. Please, okay.
Okay. So, boss Frank, so is it the too quick? Isn't it that one that they said it will cause the tachycystole?
Too quick? No. Tachycystole is whereby we are having, let's say, within a abnormal stage, whereby we're having more than 5 contractions within 10 minutes.
Oh, okay.
We're having more than 5 contractions. Within 10 minutes period, there's more than 5 contractions. And if it happens like that, that's why we are saying it compress, it cause fetal distress, because you are decreasing blood flow. So if it happens like that, know that if it's not like during the time of delivery, and it happens in, let's say you are doing contraction stress test, and there's tachycystole, it's going to cause fetal distress. That's where, in that stage, if there's oxytocin, if there's anything, you have to stop these things and give fluid and give oxygen.
Okay, boss. Thank you.
You're welcome.
I've been learning that part, but it still confuses me. Thank you.
But do you understand now?
Yes, boss.
We'll talk more about it when we reach that stage, okay? No
Okay,
problem.
thank you.
All right. Okay. So thank you all for joining today.